Good morning, everybody. So we're about to start. Are the speakers here? Okay. So only one speaker is here. All right. All right. Miss Dr. Arneja? Okay, you're here. Please come over. Ostial circumflex acute thrombosis, hanging stent across LCX ostium and acting as an nidus for thrombus formation. You have you have 8 minutes. Please try to conclude within 8 minutes. Then we'll have 2 minutes discussion. But if you overshoot your time, there will be no discussion. Okay? All right.
So good morning. Case of ostial LCX acute thrombosis. So basically we have a 55-year-old gentleman who's a diabetic on oral medications well controlled, presented to us initially in September 2023 with rest angina, positive troponin levels, normal LV function. So got diagnosed to have an acute coronary syndrome, non-ST elevation MI, and was taken up for a CAT study. And we can see that we good landing zone. And as we keep coming proximally, now we are coming to the lesion side. Basically, in the distal and the mid LAD, it was a very lipid-rich plaque with some thrombus there, which was the culprit. And so this was even this tandem lesion was completely lipid-rich. And then this was the next OCT run, which was taken from the just below the diagonal to the left main. And here the plaque morphology completely changed. Above the diagonal, we have a healthy zone, and immediately following which a very fibrotic disease starts, interspersed with calcium, eccentric calcium in between. So it was a predominantly fibrocalcific lesion from the diagonal till the ostium of the LAD. This, as we can see now, is the proximal LAD, which is again diffusely diseased as a fibrotic lesion. And as we keep coming towards the ostium, it becomes narrower with a minimal luminal area. Here at the ostium was 3.3 millimeters square with some eccentric calcium, and then we enter the left main, which was relatively healthy. So we decided to proceed with a left main to LAD stenting because there was no good landing zone in the ostium of the LAD, and we decided to proceed with 2 overlapping drug-eluting stents and using a bioreabsorbable scaffold in the mid LAD to preserve the vessel for any future CABG if required. So the mid-distal part was a lipid-rich lesion, easy to prepare, and a BRS was implanted. And in the proximal part, we used a scoring balloon for bed preparation, and then 2 overlapping 3.5 millimeter everolimus eluting stents were implanted, and appropriately post-dilated and pot was done. And this was the final PCI results and the final OCT runs. In which we can see that we have a good angiographic result, and even OCT wise we had distally more than 95% expansion and proximally more than 85% expansion with well opposed, well expanded stents and no edge dissection, no prolapse. So now he presents to us after 4 months in February 2024 with chest pain lasting for 30 minutes, gets diagnosed to have posterior wall MI, Calip's class 1, with mild LP dysfunction in the circumflex territory, mild MR, hemodynamically stable, and gets shifted to the cath lab immediately on arrival to the hospital. And this is the angiogram where we can see that the L6 ostium is now showing a critical disease with distal TIMI2 flow, and probably there's a filling defect which we can appreciate at the L6 ostium. So, and we have a relatively patent stent with mild ISR seen at the osteoproximal part of the LAD. So then we decided to do an OCT to understand what was the mechanism of the ACS before deciding the further intervention plan. So this was the ACT run which was done from the LAD, and as we can see, this we are coming from the mid proximal part of the LAD where we can see the stent is doing good with some mild neointimal hyperplasia, not much. Then as we keep coming proximally, this is at the level of the diagonal here, and again it is doing good, the diagonal goes. Then as we keep coming proximally, this is the proximal LED, where we can see we have a good well expanded stent, no significant ISR. And now as we come toward the osteoproximal part, we can see the maximum neointimal hyperplasia here. And as we can see here, at the top we saw the circumflex ostium, and we can appreciate in the still image also that we can see the red thrombus at the L6 ostium. So we knew that the posterior MI was caused because of this thrombus at the L6 ostium. So then we were thinking, what could be the reason why did he have this thrombus formation at the L6 ostium? So then we decided to have a relook at the old OCT images which were done around 5 months back at the time of the index procedure. And what we saw in multiple views that the L6 ostium was completely crowded with hanging stent struts from the left main to LED stents. And these hanging crowded struts across the circ ostium actually served as a nidus for the thrombus formation, which could have been prevented by two things, probably a more appropriate distal pot and a final kissing balloon inflation. So now we knew all the mechanisms behind the ACS. The reason for the ACS was thrombus. Why we had the thrombus? Because of the hanging struts. So we decided that we'll try to avoid any more metal at the circ ostium, left main and the carina. So first thing we did was we confirmed we had a distal cross before further intervention to avoid any struts crowding at the carina. So angiographically we were happy with the distal cross. Then we gave some GP2B 3A inhibitors intracoronary. Balloon daughtering and gentle NC balloon dilatation at the L6 ostium was done, and this was the angio result that we obtained after that, where we saw that there was clearing of the thrombus and with good TIMI3 flow. So then we took a 2.75 9 millimeter mosaic sirolimus eluting balloon, and a DCB was done at the L6 ostium, and keeping the same balloon there and taking a 2.75 NC balloon in LED, a final kissing balloon inflation was done. And this was the final angiographic result, and we were happy with it. We had TIMI3 flow and with no more thrombus. Then final LED OCT was done. The OCT catheter actually was not got damaged, was not rotating properly, but we got this image of interest here, where you can see at the ostium LED that the circ ostium is now free from any struts, and there is no hanging thrombus there now. Patient is also doing well on follow-up now, 6 months post-procedure. His LV has returned to normal, and he also underwent a stress test last month, which was negative. So osteal LCX is always the Achilles heel, tricky and difficult to treat. And here we had crowded hanging stent struts across the circ ostium, which acted as a nidus for acute thrombus formation leading to an ST elevation MI. So after we understand the mechanism behind everything, with the help of imaging, we can consider tackling these situations without more metal, and probably we could have combined physiology also along with imaging in the end to give us more confidence in leaving these situations without additional metal. And although our data is neutral, opening of the circumflex struts in a left main bifurcation provisional stentings will help prevent such restenosis. Thank you.
Thank you, Dr. Arneja. I think the case is now open for discussion. So, panelists, any comments? Okay, I'll open the discussion. So, the LED that you did, the osteoproximal LED, it looked like there was a calcium nodule there.
Yes, yeah.
And when you stented it, it was 85% compared to 95% down below. And there was very marked neointimal hyperplasia there. And that proximal LED is 3.5. You dilated with a 2.75, isn't it?
Yes,
when you did the kissing balloon. So how many months since you have done it?
So actually that kissing balloon was just to open the stent struts. We thought
I know. I mean, you were concentrating on the circumflex, but there was trouble in the osteoproximal LED as well, isn't it?
Yes, but we thought we'll not tackle that currently. We'll tackle the circumflex and we'll let him progress and come back, and we'll see how he behaves in the next 6 to 8 months and then decide.
So you are expecting some trouble there in the osteoproximal LED?
Looking at way he has behaved in the first 5 months, yes.
Yeah, okay. So any other questions? Yes.
So osteal LED, What is the vessel size and what is the stent maximum you have achieved?
Take the mic closer
Yeah,
to your
so
mouth.
vessel size there was 3.6 millimeters, and 3.5 millimeter stent was put from the left main to the proximal LED, and post dilated at high pressures with a 3.5 NC, and the left main was post dilated with 4 millimeter NC balloon at high pressures. Left main was 4.2 millimeters.
Okay.
Do you think FFR pullback or any physiology would have changed your strategy in this case? Since your
For
lesion in
the
the mid
LED
was
or for
tight,
the circumflex?
your prox LED was little borderline, and you had a good landing zone in the mid LED just to cover the,
Yes, so
physiology could
prox
have
LED,
added-
actually we thought that we'll probably after 6 to 8 months reassess him. Currently we just took care of the
Your MLAs
posterior-
were tight in the osteoproximal LED, that is accepted, but maybe physiology could have added some more information for the prox LED so that you could have left it behind for the
That,
future.
but one thing was that unfortunately right from the left main till the distal LED he was having metal and then a BRS. So probably physiology might, the vasomotion of the vessel would not be there because it's a completely caged vessel currently. So it might not be a very helpful test probably.
This is just a thought.
Last question. Yeah.
I think LAD is always LAD. It's the largest artery. So you had seen in this second intervention that there is some lesion in the osteoproximal. There is some instant restenosis in the osteal LAD. I think anyway you are intervening in the circumflex osteum. I think, it's very easy to comment sitting here. You should have been a little bit more aggressive there, should have used some cutting balloon, got the stent expanded in the proximal LAD rather than waiting for a third procedure. This is what is my honest
Okay. So we are all agreed on that. That is, you did very well on the circumflex, but expect some trouble in the LED later down the line. Okay. Thank you, Dr. Aneja.
Thank you.
Dr. Pankaj Manoria, are you here? Yeah. Seeing is believing. Again, remember 8 minutes. Please complete by 8 minutes for 2 minutes discussion.
Thank you, chairpersons. Basically, I will be presenting two cases to justify the point that seeing is believing. That means looking actually what is happening in a case of stent failure and then planning treatment according to the etiology of the stent failure. That is why I say seeing is believing. This is the case 1. This was the baseline angiography showing a tight proximal LAD stenosis, and after post-PTCA with a drug-eluting stent, the results look reasonably well. But after around 7 to 8 months, patient again had an angina, and now you can see ISR in the osteoproximal segment of the LAD stent. Now what has led to this ISR is, we know that there can be, ISR could be because of multiple reasons. It can be because of stent-related issues like underexpanded stent or a stent fracture. It could be because of new intimal hyperplasia, and it could be because of new atherosclerosis. So what actually is the cause in this case? It can be only assessed with certainty when we do imaging. That's why I say seeing is believing. So when we did the IVUS, we wanted 3-4 questions to be answered. First of all, what is the cause of ISI in this case? Whether it's underexpanded stent or this new intimal hyperplasia or new atherosclerosis. Secondly, whether the ostium has been missed, that means, is there any geographical miss? Number 2. And number 3, is the disease, is the stent extending up to the left main? Because if the stent is extending to the left main, the treatment might change. They all depended upon what was the IVUS finding. And the IVUS clearly showed that the stent in the ostial segment was underexpanded. Number 2, there was no geographical miss. That means the ostium was well covered with the stent. And number 3, the distal left main was free of disease. So a lot of information we gathered from the IVUS, and then we planned a treatment accordingly. So what we did was, this is just to show the stent in the osteoproximal segment was underexpanded. If you look at the vessel areas for around 12, and the stent area was only 6.2. So the gross undersized, underexpanded stent was the main cause of ISR in this case. What we did was, we first used a cutting balloon of 3.5 into 6, and then we further dilated with a 4 into 10 NC balloon at high pressures. And then again, we used a DEB in the end. And what we found, this was the angiographic result after doing a repeat angioplasty with a cutting balloon and DES. And this was the final IVUS which we got in the end after doing everything. Now here you can say the final MSAs was around 11, you can say. And This is just to give you the comparison angiographically. In the first instance, we could get an MSA of only 6.24, though the angiographically the result was looking better. But here, after doing with the IVAS guidance, the final MSA achieved was almost 11. So gross difference in the final MSA, under expanded stent was the cause of ISR in this case, and a POBA was done and everything was done, and it looked fine. So that is why I say seeing is believing, actually seeing what is happening and then planning treatment accordingly. The second case, this was the case of a 55-year-old female who had a proximal LAD lesion again, and after angioplasty again you see the results is looking reasonably well, nothing underexpanded on angiographically. And after 5 years again this lady had a severe chest pain and she was admitted, and when we took her for angiography, it again showed a tight ISR in the LAD stent. Now again, the same question, what is the cause of ISR? Whether we are dealing with some stent-related issue, it is new intimal hyperplasia or NIH. Again, we need an IVAS to answer all these questions. And when we did an IVAS in this case, again, it showed that now this time the stent was very well expanded, but it is basically the new atherosclerosis which was the cause of ISR in this case. As you can see on the IVAS, the stent area was or around 11.8. That means the stent was very well expanded. It's just the new atherosclerosis which was responsible for this failure of stent. So again, we planned this case. We again used a cutting balloon, and the NC balloon was used again for further dilatation. This we got after doing a balloon dilatation. And when we again repeated the IVAS after doing a cutting balloon, the MSAs, which was the MLA, which was 3.3, which again, it rose to around 7.84 after cutting balloon. So we were in dilemma whether to put another stent or not, but the lesion was looking hazy. There was some thrombus inside the stent also. So we planned to do another stent, and another stent was deployed, and which was post-dilated at a high pressure. This was the final angiographic result, which you can see. And again, just to confirm whether we have done a good work, again we did an IVAS. This is just to show the comparison of IVAS images post-cutting balloon and post-stenting. It was 3.3 to start with. It rose to 7.84 after a cutting balloon, and finally the MSH which we got was around 10 millimeter square. This is just correlation with the angiography. You can see where we started with after cutting balloon and after putting the stent. That is why I say seeing is believing, seeing actually what is happening inside the stent, and then again plan your treatment accordingly. So just to summarize, I can say imaging helps us in doing precision angioplasty without any guesswork. We don't need to do any guesswork. Everything is visible. What is the cause of ISR? How we should plan? Where is our stents extending? Everything was very clear once you do imaging. We identify the mechanism of restenosis and we plan the strategy accordingly. And finally, we do the post-procedure imaging to optimize the result and see whether we have done a good work or not. Thank you. In the end, I can say intervention, intracoronary imaging are the glasses of modern-day cardiologists who do not like blind decisions to make.
Thank you, Dr. Manoria. Can you show us the LAD, the second LAD stenting after you had...
Cutting balloon?
No, the first, at the end of the first angioplasty. The second...
Second case?
The second case...
Angiography?
You showed both before and after. So let us see this. Yes, okay. So this is a big diagonal, and the diagonal had gone down at the end when she came back with restenosis. And you didn't do anything to the diagonal?
No.
Why was that?
No.
That is a big diagonal. That is at least it's more than 2.25. It's like 2.5. It is going through the stent. I accept that. But you should have wired it. I mean, you could have opened up the stent strut. That is a large stent.
The diagonal was wired, but I didn't do the final casing at the end. It was wired. This is the final picture which I have shown you.
No. The second case. Show us the second case. This is the first, February 2018. Yeah, here you can see. So where is the wiring of the diagonal?
This is the angiography only.
Yeah, show us. Keep showing us. You concentrated on the LAD, but my point is that the diagonal was also a large vessel. You should have wired it and at least opened up the stent strut and seen what had happened there. But anyway, your optimization of the LED is excellent, but just don't ignore the side vessels if they're big. Huh? Okay, any other questions?
Regarding first case, was the eye was done in the initial sitting? No. Okay. If it was done, probably the second you would have prevented.
Sometimes in this case of underexpanded stents, OPN balloon does a great job actually.
But
Especially
we
if
got a
there's an
very good
underlying
result, yeah.
calcium and you had missed it in the previous angioplasty. And now that becomes the cause for ISR. And then you can expand the stents very well. OPN does a great job.
Yeah.
Here you do not have any calcium in the osteoproxial LAD.
Yeah, I agree.
True. OPN is actually better than cutting balloon in these cases because you can go up to very high pressures. Any other questions? Okay. Thank you, Dr. Manoria. Next is Dr. Shahir Ahmed. Is he here? Dr. Ahmed? Yeah. A curious case of FFR-guided PCI in chronic stable angina. 8 minutes, Dr. Ahmed.
So very good morning to you all. My case is a 50-year-old male who was an ex-smoker and dyslipidemic. Had presented with angina and exertion class 3 for the past 4 months. He had a normal early function. TMT was with strongly positive with the exercise capacity of 8.2 mets. His coronary angiogram had shown a LM ostial mild plaquing, LAD mid 70% stenosis and distal LAD 50% stenosis. LCF is dominant with a mild disease and RCA was non-dominant. So this is the angiogram you can see. Can see a proximal, mid LAD around 70% stenosis and distal LAD you can see there is a mild disease here. So, since the lesion was not too tight and he had a class 3 angina, we decided we'll do FFR first and then proceed with the PCI if it is positive. So we took a 6-French right femoral access with the GL 3.5. But however, on engaging in the left main, there was some ventriculation of the pressure trace. So we decided initially that we'll do a IVUS of left main to rule out any significant LM disease and then proceed accordingly. So we did a IVUS to the LM. You can see we got a lumen area of 6.85 millimeter square, which was not significant based on imaging, even for the European populations. So since LM stenosis was not significant in IVUS and angiography also there's not much stenosis and excess was relatively okay for considering having a significant LM disease, we decided to proceed with FFR and PC of LAD. So this is a FFR of LAD. So we can see the basal PD by PA here, which is 0.84 and post, we gave intracoronary adenosine and post adenosine FFR is 0.77. So we decided to go ahead with PC of this mid-LAD lesion. So we pre-dilated with 2.5 into 12 mm SC and dilated with, stented with 2.5 into 16 mm DES and post-dilated with a 3 mm NC balloon. So then we repeated the FFR to see whether we had done a good job. But however, again, you can see the post-PC FFR is again still 0.75. So then we probably thought, see, this might be the lesion which is causing this and subsequently decided to stent that. So we stented that with the 2.5 28 mm DES and post-dilated with the 2.75 NC and repeated FFR, but again to our surprise, again it was still positive. So now we decided we'll see where exactly the lesion is and we'll decide to do a FFR pullback with the IV adenosine infusion. So now we can see we did a FFR from both L6, LAD to LM and L6 to LM, and now we found that actually the main culprit is actually the LM. It was not LAD all throughout. But however, when we looked at the IVUS, the area was not significant. It was 6.85, which is not considered as a significant disease. So that time we could not do it because of logistic issues. We decided to call him after a month and finish the PCA, but he was still having class 3 angina. So subsequently, we did his PCA of LM with the 3.5 into 24 mm DES from LM to LAD and did a pot with 4.8 mm NC balloon. We did a IVUS post, which showed a LM ostial MSA of 12 millimeter square. And we did a FFR finally to look how things are. So the FFR had improved to 0.84, but it's not optimal for a post-PCA result, where we expect at least a 0.9 FFR. Again, we did a pullback. Again, you can see again, the loss of pressure happens only in the left main, not in any other part of the vessel. Subsequently, however, his symptoms had improved. He had only angina on heavy exertion, which we managed with the anti-anginals. So, thing is, it was a discrepancy basically with the imaging parameters and physiology of the left main, where most of the data we can see area of more than 6 millimeters considered safe, and we can leave the left main lesion. So probably explanation we felt was, since the left main was a dominant circulation, maybe that much of decrease in area also had caused a significant physiological stenosis. And LM also had a diffuse long disease, and as we know, the length of the disease also corresponds to the pressure loss, so probably that might be a mechanism. And thirdly, maybe the LM plaque was majority lipid rich, and we also have data showing that lesions with more posterior modeling, high lipid burdens and plaque burden more than 60 tend to have more positive FFR. So the take-home points from this is the angiography might be misleading in the case of LM disease, and intracoronary imaging should be done for patients with suspected LM disease. In patients with chronic stable angina, FFR is vital in guiding doing PCA of the correct lesion. And FFR pullback is available in case where FFR is disproportionately positive with respect to the patient's angiographic findings and symptoms. Thank you.
Thank you, Dr. Ahmed. So you have looked at the correlation after this case, the research data. Did you look into the correlation between FFR and minimum lesion areas in the left main, the research papers, and how they came to the conclusion that 6 is the right? So it is a comparison of a lot of patients with a lot of MLAs and FFR values. Yeah. And 6 is, it's like a value that has been averaged from a lot of data, and that is the most important thing. And usually if it is greater than 6, it doesn't matter. But that does not mean that it will never matter. That is the learning from this case. And the other thing is that when you were having problems with the mid and distal LAD, the LAD, mid and distal LAD, I would have expected, since you are doing IVUS, to look into the LAD to see whether the stents are well expanded or not. I mean, I couldn't see you going back and expanding the stents a bit more. So these were 2.5 stents, weren't they, in the mid and distal LAD? And if you go back, if you show us that LAD, second LAD stent, can you go back to the presentation? Can you have, yeah. So you can see that the top part, no, just play this picture, yes. So this is the second stent, right?
Yeah.
2.5 by 28, you can see that the top part of the stent is not as well expanded as the bottom part. Look at it carefully.
Yeah.
It is constrained there. And my reaction would be, if this was still positive, is to go and dilate that proximal part of the stent. Did you do that?
So this is the image after
so I'm saying that the proximal half of the stent, which does not look as well, even on angiography, you don't need IVUS for this.
Yeah, it was post-dilated. And
did you do post-dilatation after you did the FFR?
Yeah.
But you didn't mention it.
Yeah. But again, on pullback, that pressure loss was
yes, I know. I mean, your diagnosis was right, but this is also not ideal. You could have done more on this. Yeah. Okay. Any other questions?
So in the initial FFR, which is the maximum point of decrease in the point from the middle LAD to distal LAD? That is the maximum point of.
It was in the middle LAD only.
The middle LAD.
Sorry, initially actually during the baseline we didn't do a pullback actually. Okay. So that probably could have been done at that time. So since it was the most angiographically tight lesion, we thought probably that is causing the ischemia, and we started sending that first. But then when again the FFR came positive, then probably because the IVUS actually totally carried us away, because the IVUS area was more than 6, was not expecting at all that the LM as a culprit for all these FFR findings.
And one more thing, in ostial LAD, ostial left main, during FFR, always put a wire on the L6 and measure at the initial stage itself.
Yeah.
Because when you're engaging in the left main, this will alter the value of FFR. Because you should take the guide from the left main, then you should do a pullback. Thank you, sir.
Okay, no more questions? All right. Well, thank you, Dr. Ahmed. The next presenter is Ajit Kumar Krishna Jadhav. Dr. Jadhav? Yeah. Delicate Balancing Act, Ultra Low Contrast PCI in CKD patient. 8 minutes, Dr. Jadhav.
Very good morning to respected teachers. So today I'll be presenting.
Can you reset the clock, please? Just one moment. Yeah, go ahead.
So my patient, 67-year-old male, diabetic with HbA1c of 9.2, hypertensive. There was a renal dysfunction, creatinine of around 2.7, but he was not on any dialysis episode prior, with the EGFR of 25 ml. We had did already PTCA to RCA in August 2023. There was a RCA CTO which was we opened with the 3 drug-eluting stents, and he was planned for a stage PTCA to LAD, the 2 drug-eluting stents. So we planned this time under the guidance of IVUS with the ultra low contrast. So start with to recreate the anatomy of the we use a diagnostic image as a reference for our PTCA. So what we usually need is creating the anatomy with the 2 PTCA wires, but for that we need a large bore double Y hemostasis valve, but we don't have this valve, so we did a small desi jugaad from our cath lab. We have put 2 push Y click connectors in a series. So this multiple guide wires can be used to recreate the anatomy, and it will be helpful to you for the wiring the main branch as well as relative side branches for the reference. So for the guide catheter engagements, we have confirmed this with the 10 to 20 ml of normal saline injections, where we can see that there is some changes in the STT depression as well as T inversions. Sometimes we will get some amplitude increase in the T wave. So this was the LAD. There was a lesion in the osteoproximal LAD, and immediately after that there was a tight critical stenosis. So, and in the mid segment of the LAD also there was a critical lesion. So we wired the main LAD and we did the IVUS. So and in the LMC it was 12.54, in at the LAD ostium it was 6.6 with the plaque burden of around 50%. So we are planning to leave the LAD ostium at present. And the proximal reference was 9.9, and the tightest portion was showing only 1.8 millimeters square, with the distal reference of around 3.2. So we are planning from proximal LAD to the. So we have recreated the anatomy just with the BMW and run through wires, and we as we had the IVUS reference for that, we pre-dilated the lesion with 2.5 by 15 millimeter balloon, and we have stented the mid segment of the LAD with the 2.5 by 28 millimeter stenting. Now for the proximal LAD, we took 3 by 20 millimeter stent. Again, it was done under the guidance of the recreated anatomy, and we did stenting of the proximal LAD, leaving the ostium apart, which was post-dilated with the 3.5 by 12. So there was, after the stenting, we did the IVUS, which showed that there is some proximal hanging struts in the proximal part of the stent in the LAD, and the stent edge, there was initial hanging with. So we did the post-dilatation of the stent, and this was the final results what we got. So though there was a proximal lesion seen at the ostial LAD, but as the IVUS has shown that there is a 6.6 area with plaque burden of around 50%, we have not done anything over there. So this is what we can use, this Philips dynamic coronary roadmap, where the real-time guidance can be achieved with, we can navigate with the confidence, and they do have a seamless integrations for that. So for the take-home message from my case, it was coronary revascularization is usually denied in CKD patients and elderly patients with the borderline renal function as well as low ejection fraction in the fear of contrast-induced nephropathy. Alternative contrast-free approaches such as the guide catheter engagements, vessel wiring, location of the target stenosis, and the optimization of the stent deployments, we can use, there are many other techniques. The evolution and wider availability of a navigation technology such as a dynamic coronary road mapping or IVUS or OCT or IFR co-registrations can also be used in such cases. The use of final contrast run for the treated vessel, which has a medico-legal, and it also ensures the visualization of potential complications such as distal wire perforations or side branch occlusions. Thank you.
Thank you, Dr. Jadhav. Now it is open for discussion. Panelists?
What was the time interval between
proximal end of-
RCA and LED flash?
So it's more than 3 months, sir.
3 months. What was the amount of contrast you used in second sitting?
So it's around for 15 ml, sir.
50.
15 ml, yeah.
The proximal end of the stent is landed in a LED with a 50% plaque burden, right?
Sir, actually it has been landed just beyond that plaque, but there is some plaque at the ostial LED itself, but which is the burden is around 50%, so we have left intentionally, sir.
At the landing
Landing was, okay sir, landing was not having any issue. Landing at the part of it, because IVUS didn't show any, it was showing some stent overhang initially, but we have post-dilated with the 3.5 by 12 NC, and which again later shown no stenosis.
Show us that run from the proximal LED proximal LED stent, where on angiography there looks a little bit of under expansion in the proximal part of the stent, and we want to see how it looks on the IVUS. And while you are showing it, Dr. Manoria, you can ask your question.
Dr. Jadhav, how do you make sure that you are landing your stent exactly in the place you intended to land?
Okay,
What technique
yeah.
did you use during,
Yes, that's a good
without
question.
dye?
Let him think about that. He will answer it. Okay.
Yes.
So show us that, no.
So as we have recreated the anatomy with the 2 wire in place, and we have measured the distance from the distal point of the landing of the stents, as well as from the, so as you can see, when we have removing the wire, the stent has been placed absolutely at the tip of the radiopaque wire.
Did you use the marker wire technique or the cardiac salute technique? Which technique did you use?
I didn't get a question, sir.
Did you use the marker wire technique, the second wire, and you place your stent exactly at the radiopaque tip of the marker
Yes.
wire?
Yes,
Or
yes.
you use the diagonal as a reference branch?
No, sir. We have kept our marker wire as a reference, because as we know that the IVUS at the point of the landing, we have kept our wire at the point.
Okay, so just show us that final IVUS run. Yeah, so this is your second stent. This is a 3 and you have post-dilated it to a 3.5. And my point is that the proximal 5 millimeters, it looks a little under-expanded, but I just want to, yeah. Can you see that?
Yes, sir.
It is also visible in this areocaudal view. That
Yes.
just show us the IVUS run and what was the stent area there. Do you have a run, or are you just showing us cuts? Yeah. Do you have a long view layout? No. Okay, so when you are presenting, it is better to have the long view layout as well, okay, because it is very easy to look at stent expansion. Here, I am not sure which part of the stent I am looking at.
Okay.
And it looks to me that probably there is this on the top left panel.
Top left parameter.
What you are showing, is that the prox LED?
No, sir. That is distal, sir.
And on the right is the prox LED?
Yes, sir.
Okay, so, and you are coming from proximal, from distal to proximal.
Yes.
But the run is not very long. It is
Yeah,
a very
it is
short
short
run,
runs, yeah,
and
short
it doesn't cover the whole stent.
Yeah, I think in view of time, probably we need to...
Yeah, okay.
Thank you.
Fine.
Thank you, sir.
All right.
Thank you very much.
Thank you, Dr. Jadhav. And Dr. Raja Ramesh, optimal use of intracoronary imaging for recurrent stent failure management. We are just running 5 minutes late, so we should be okay. 8 minutes for you, Dr. Ramesh.
Yeah. Thank you, sir. Thanks for the NIC for giving me the opportunity. So in this session of imaging and physiology, I would like to present a case of recurrent stent failure management with optimal use of intracoronary imaging. So our patient is a 58 years male, diabetes and hypertension. The story starts in October 2023, had an episode of unstable angina, and he underwent PCI to proximal LAD, which was done outside. The stent details were not known, the diameter and length of the stent. In December 2023, that is the 3 months after, he had an episode of STEMI. Again, it showed an ISR 90% in the proximal to mid LAD, and this stenting was also done outside. Now we have the stent details available. It is 2.7528 drug-eluting stent. In March 2024, he presented to our institute again with NSTEMI, this time with LV dysfunction also. And this time, again, the CAG showed a ISR 90% at the overlapping of the stents. The initial stent was done in the proximal LAD. Later, he had an ISR starting from the middle of the stent, extending distally. So we thought of we'll address this by image guiding. So this is a CAG at the first episode of ISR in December 2023, showing 90% stenosis both in the caudal and cranial views, starting from the middle of the stent and extending distally. And then he underwent stenting with 2.7528 DES. This is also everolimus eluting stent. We have that data. And overlapping the proximal stent, extending into the mid LAD. So angiographically, the result looks good. So this is the time he was presented to our institute. This is the second episode of ISR. So, 4 months after the second stenting, showing 90% stenosis. This time the TIMI flow was also reduced. And ISR, we can see at the overlapping part of the stent, the ISR started and extending into the mid LAD with reduced TIMI3 flow, and this time with LV dysfunction also. So we thought of, we'll do an OCT for this patient to know the mechanism of the ISR, whether it is a mechanical cause like stent underexpansion or undersizing the stent, or it is a biological cause or any like neoatherosclerosis or neointimal hyperplasia. So the lesion was wide with run-through wide, and to facilitate the OCT catheter, as there is a reduced TIMI flow, thinking that the dye may not clear, we have pre-dilated with 2 mm NC balloon, and OCT was performed to understand the mechanism of the ISR. And this is the first run of the ISR after dilatation with the 2 mm balloon, which is showing neointimal hyperplasia and under-expansion of the stents. So I will show in detail in the next picture, frame by frame. So the proximal reference diameter of this LAD was 3.5, the distal was 3.2, and there is a neointimal hyperplasia, had evidenced by here the layers of fibrous tissue. And more importantly, the outer stent, the diameter was 2.8, and the inner stent, the diameter was 2.47. So it was, the cause of this ISR is both the undersized stent and the underexpanded stent. And the causes are both mechanical and biological. So there is an underexpansion of stent, undersized stent, a 2.75 stent was placed in a 3.45 vessel, around 3.5 vessel, and there is an neointimal hyperplasia. And now we have left with, we are thinking of the options for this patient to give another layer of stent, or to go with the drug-eluting balloon, or to give an option of Lima. We thought of we'll give this patient a drug-eluting balloon. So we start with the lesion preparation with 3 mm Wolverine cutting balloon, thinking that we'll break those neointimal hyperplasia, and then dilate it with 3 mm NC balloon so that we can expand the previously underexpanded stents. So this was 3 mm Wolverine cutting balloons dilated starting from the mid into the proximal LAD. And again, OCT was performed after the cutting balloon and the high pressure balloon. So now the OCT shows well expanded previous stents, but still there are some layers of neointimal hyperplasia, especially at the distal part of the LAD, where the area was only 3.84. In the proximal part, we are satisfied the stents were expanded up to 3 mm, and the MLA is around 5.25. So to gain further lumen before applying the drug-eluting balloon, I have taken a 3.5 NC balloon and further expanded the previous stents. And then a 325 sirolimus drug-eluting balloon was applied, which was well expanded without any waste. And the final angiogram was done in both in caudal and cranial views, which shows good T3 flow without any flow-limiting dissection. And this patient has completed the 5 months of follow-up till now, no further symptoms. So to conclude, the recurrent ISR is not unusual in contemporary practice. The recurrent ISR can occur in approximately 20% of all ISR cases. The use of intracoronary imaging provides insights into the underlying mechanisms, whether it is biological or mechanical, especially the OCT, is better tissue characterization can be possible. And lesion preparation in this ISR patient may sometimes require special balloons like cutting balloons. And patients with recurrent ISRs are usually refracted to the usual treatment modalities. So now we have this option of drug-coated balloons may have beneficial effect in the recurrent ISR. Thank you.
Thank you, Dr. Ramesh. And questions? Okay. Questions?
I felt the overlap of the stents, the proximal and mid,
Yes.
was a little bit more than what is usually there. I think
Yes,
it
it is around 5 to 6 mm, and it is the area where the maximum under expansion of the stents was there and formed a nidus for the ISR at that point, which extend further into the mid LAD.
the NIH there was very high in
Very
that
high,
area where the
because
overlap was
there are 2 layers, that too with an under expansion.
That's the major problem. The more, I mean, whatever amount you keep on expanding or trying to expand it, that it's like an onion peel thing.
Yes, sir.
The thing which is there in between these two stent struts is never going to yield in a very big way. You will never be able to oppose these two metal to metal.
Yeah, that's why, sir, try to gain as much as MLA before applying the drug-coated balloon and finish.
So what was your final MLA?
Sir?
Final MLA was what? At the
No, after drug coating.
After the cutting balloon. Drug coated balloon will not increase your MLA.
Yes, yes. No, it was 5.85 mm square.
5.85.
Yes.
Okay, that was the minimum, and the rest was more than that, right?
Yes, sir. That's
Okay. Okay. Thank you, Dr. Ramesh. And we go to the last
change
case.
in DAPT strategy?
Sir?
Did you?
No, sir. Because there are already 2 layers of stents with some under expansion. I think these patients require dual antiplatelets. If only drug-coated balloon is there, then we could have choose a single antiplatelet. But this patient I have kept on dual antiplatelets.
For how long?
Sir, this right now he's still in 5 months. He's still on dual antiplatelets. Sir. Maybe we thought of we'll continue for at least 1 year.
Okay. Okay. Thank you, Dr. Ramesh. And we come to the last case.
Thank you.
Imaging and physiology in a case of cardiomyopathy. Dr. Rajendran. Okay.
Good morning, chairpersons, and thanks for the opportunity. It's just the case is interesting because the way we approached the case and the way he presented to us. So he was a 50-year-old male, a chronic alcoholic and a smoker. It's a hypertensive, but not a diabetic. So it's a poke drug complaints present, who had a progressive dyspnea on exertion. He presented with acute worsening breathlessness following an episode of fever cough. ECG showed some features of ischemic changes in the form of Q into 3 AVF, but there was LAHB also, and there is LVH also. Echo showed a dilated hypertrophic LV with severe global LV dysfunction with an accentuated hypokinesia of infraposterior wall also. And there is some MR that is more than mild, and HS troponin was elevated but flat. It's not showing the typical step up, and so it is myocardial injury versus ischemia, but more favoring injury at the time of this presentation. And the cardiomyopathy with severe LV dysfunction, either due to hypertensive, alcoholic, or ischemic, is the basic diagnosis with an acute decompensation. Usually it's in the warm wet type because the BP was high, but there is edema, both peripheral and systemic congestion. And this illness is probably the reason for decompensation. It was a Klebsiella pneumonia in sputum, and that time it was COVID also. It was negative. It's treated with antiplatelets, statins, and diuretics, with all the guideline-directed medical therapy, along with lifestyle measures to quit smoking. So the patient improved rapidly with this medication, discharged home. And 2 weeks later, this was the angiogram. Had significant disease all over the coronaries, not a smooth vessel. And but the lesion that is significant is in the circumflex. The LED is showing serial borderline lesions. LM is also showing some disease, but not borderline. RCA is relatively better with some mid-PDA lesions. So how we approached this, we were convinced about this occluded OM and the critical distal LCX and the last OM disease, but the LED lesion was quite borderline. So whether it could explain the severe LV dysfunction, we are not sure, because the cardiomyopathy due to ischemia requires a left main disease or critical TVD, including a proximal LED critical lesion, though there were some serial lesions which should have a cumulative ischemia. So because he had some MR and infrapostural hypokinesia and AQA, we went ahead with fixing the circumflex, but realized it's a tough lesion because there was double bends in the cranial view, and after the balloon dilatation, even a buddy wire to facilitate the stent is not going, probably due to balloon-induced dissection. So we exchanged with the microcatheter to a Grand Slam wire, but still the stent was not advancing, and it got damaged while we take it out, and it got almost crumpled. Luckily, it was within the guide catheter. We pulled away the whole system, but it got stuck at the distal radial sheath that was snared with the peripheral snare, and then re-engaged, we recrossed, we dilated. This time straight away went with the guide extension catheter with balloon anchoring technique, and you could see the stent is now could easily delivered. 2 long stents fixed. The OM got too thin and couldn't be crossed, so we left the middle OM. And then the patient was kept on guideline-directed medical therapy for heart failure along with dual antiplatelet statins. The LV improved marginally. The MR also improved, but there was no angina on excision. The patient continued to be having breathlessness and requiring escalating dose of diuretics. We brought him back to assess the lesion significance of the LAD. So the circ stent was patent, and this was the RFR. We don't went ahead with the FFR because it's quite significant. It's 0.67, and so there are 3 serial lesions. When we did a pullback, it was interesting that the step-up was, we expected at the middle lesion, but the step-up was maximum across the proximal lesion. And so the step-up was around 0.22, whereas the other 2 lesions just had 0.003 and 4. So we went ahead with an OCT to define what's happening. It's probably an organized recanalized thrombus that's there at the lesion corresponding to the proximal LAD lesion. The rest, the middle one had a ruptured plaque, and the distal lesion is nothing, just a calcified plaque and not significant. Because only the 2 proximal lesion is what was most significant, we fixed it with a 3 millimeter stent and post-dilated with 3.5, and the OCT showed a good result. Here again, the discharge of the stent was fine, started flowing, but we could see that the whole lateral wall is bald without any major vessels, but even the collaterals that's filling is too small to give an attempt to open those vessels. So we accepted the result. We did a post-PCI FFR, RFR, which was 0.92, and the patient was continued on medical therapy and showed a significant improvement in the LV function within a couple of months. And so probably it's a case of ischemic cardiomyopathy, apparently having an SVD, just a haziness in the LAD that cannot explain the LV dysfunction. But physiology helped in identifying the ischemic nature of the LAD lesion, and pullback FFR localized the step up to the proximal LAD lesion. And OCT imaging helped to understand the pathology and also the optimal stenting. Not to forget, the guide extension helped in the initial circumflex stenting. The LV function, the LV remodeled, and the LV function improved. We know that the physiological evaluation of ischemic potential for intermediate lesions is validated for patients with severe LV dysfunction, both in experimental studies and also these propensity score match studies, and also a sub-study of the FAME trial. They have shown that though the LV EDP and the RA pressure is high, the chances of a falsely high FFR and missing out a lesion is possible, but in the outcome studies, it did not have affected the use of FFR. Because and so this recurrent and persistent heart failure in patients with borderline CAD, where physiology can help to identify the etiology. Thank you. So angiogram is a shadogram, and we can miss lesions with just an angiogram, as in this case, and we can use anything to get a shadow what we want. Thank you.
Thank you, Dr. Ravindran. So last case and questions from panelists. So what is your take home from this, apart from all the messages that you showed? So if you were faced with a similar case again,
Yes, sir.
what would you do?
Maybe even in this case, I would have done the physiology of the LED in the first setting itself, but that time we were not having on table, so we don't have the FFR machine on that day, so we have to bring him back. But subsequently, it took some months together, and we also found that the initial stenting to the circumflex and medical therapy is not working in this patient.
True. Okay. Any other? Yeah.
You showed, in initial echo showed a global hyperkinesia. But
Pardon?
the L6 delta is not supplying the interval.
Yeah, it's supplying, but there is another OM that is occluded, and the diagonal is also occluded. Both should take care of the lateral wall, but they are all diffusely diseased vessels. Only the last OM is taking care of the lateral wall.
Sir, any viability study would have added to your decision making?
Yeah, definitely viability studies are valid. As of now, it's a class 2A indication, but in this patient, it is the echo-wise, the wall thicknesses were preserved. And also the ECG was not showing any signs of anterowall damage. It's fully preserved R waves in the anterior leads. That's why we approached this case as a cardiomyopathy case rather than an ischemic cardiomyopathy from the beginning.
Okay. Any other? No? Okay. Okay, any questions from the audience? Because we are going to wrap it up. All right. Okay. Thank you very much, Dr. Rajendran. With that, we come to an end. I thank all the moderators, chairpersons, panelists, and the presenters, and the audience who have been around to appreciate this challenging CD presentation session. Thank you very much.
The topic for this session is IVAS. The facilitators for this session are Nishik Chandra and Arun Mohanty. The chairpersons for this session are A. Adar Sahil, Balbir Singh, D. S. Chadha, Sajeev A.T., Praveen S. and Gopi A. The panelists for this session are Preeti Sharma, Mohajib Arneja, Imran Hafiz, Siddhant Prehan, S. Selvamani, and Neeraj Rathani. The discussants for this session are Bindu Nahata, Purneshwar Pandey, PVVNN Kumar, Anup Velagar, Suhasmita Sahu, C. Indu Prakash Reddy, Varun Kumar Gupta, and Mahmood Sulaiman.
So, good morning, everyone, and this is a session on imaging IVAS, particularly. Are we full? Anyone joining in the dais? Dr. Silvavani is coming. Dr. Bijay is here? Hello? Dr. Bijay Kumar? I saw him somewhere. Okay. Yeah. Oh, yeah. So, without delay, we should start the first talk. That's on, what is that topic? Yeah. The first talk is by Dr. Pankaj Manoria, case-based discussion on acute MI. Pankaj, your time is 8 minutes and 2 minutes discussions, please.
Present few cases to emphasize the point that IVAS can play a very important role in acute coronary syndrome also. Yeah. Point number one, or case number one, you can say. This was a case of 65-year-old gentleman, acute anterior MI, who presented late to us. He was non-thrombolized, so he was taken for an angiography and angioplasty, and this was the culprit mid-LED lesion. We wired the lesion and dilated with a 2.5 balloon. The balloon ruptured and the artery closed. Now, the patient had again severe chest pain. So what is the cause of abrupt vessel closure in this patient? Is it air embolism? Is it slow flow? Is it dissection? Is it thrombus or spasm? I'm sure nobody can tell with certainty that what is the cause of this complication or why the vessel is closed. But since we had an IVUS, everything was very clear. When we pulled back the IVUS, did the IVUS, it was very clear that is a clear-cut dissection which has caused the abrupt vessel closure, and the treatment was planned accordingly. Without IVUS, it was difficult to plan the treatment because it will depend upon the cause. What is the cause? Then only we can plan the treatment. Here it's very, just put an IVUS, everything was clear. There's no spasm, there's no air, there's no thrombus. There's only dissection which has causes abrupt vessel closure. And not only it has helped me in diagnosing the cause of complication, but also in planning the treatment, what size of stent I am supposed to take, where the dissection is starting, where it is finishing, what is the length of the stent I am supposed to take, where to put the stent distally and proximally. Everything was very clear. So it was planned, and just I did put a stent, and the flow was restored. So IVUS can play a very important role, not only in identifying complications during acute MI, in helping in managing it, differentiating slow flow from dissection, and identifying various causes of abrupt vessel closure. Just put an IVUS and everything will be very clear. Second important case. This was a 50-year-old gentleman, acute inferior volemi. This was the baseline ECG. RCA showed a total occlusion in the distal segment. Primary angioplasty was done. The flow was restored. Angiographically looks very well. So patient was very happy, I was very happy, relatives were happy, staff was happy, everyone was happy, but our happiness didn't last long. After a few days, again patient had a severe chest pain, and he was in the periphery, so he was thrombolized there, and subsequently was referred to us for evaluation why was the stent got blocked. Luckily, the artery was flowing when he came to us again, but he had a lot of thrombus there. So we did an IVUS to see exactly what happened, why did the stent got occluded. And when we did IVUS, it was found that the stent was a grossly undersized, underexpanded stent, which has led to acute stent thrombosis, which angiographically looked reasonably well. So this time, you can see the vessel area was almost 20, but the stent area was only 7. So this time, the stent expansion was only 59%. So what we did was, again, we did the complete procedure, we dilated again, and this time the final MSA, which we could achieve after plain balloon dilatation, was almost 12.7, with the stent expansion was almost 100%. So you can see this was the first, this was just when we started with, the MSA was only 7.3, and when we finished, it was around 12.66. So angiographically, you can see both the procedures, they looked almost identical. But on IVUS, it was found that the first procedure, the MSA was only 7, grossly underexpanded according to the size of the vessel, which led to stent thrombosis. And the second procedure was IVUS guided. You can see the MSA achieved was 12. So angiographically, it can lie sometimes. You're not sure what is the stent expansion. That is why IVUS is very important in acute MI to assess the stent size and prevent stent thrombosis. The third case, I'll give you 3 cases in the third spectrum. These all 3 patients are acute coronary syndrome, STROP3 positive. Can anybody tell us what is the cause of acute coronary syndrome in all these 3 cases? It is difficult to say. You can say, but you can't be certain. But when you do IVUS, you're very sure that the first case is because of a calcified nodule, eruptive calcified nodule. Second was a case of plaque rupture, which led to thrombus formation and acute MI. And third was a case of SCAD. So all 3 were acute chest pain, STROP3 positive, but had different etiology. And IVUS can very clearly tell us what is the etiology, because this is very important to plan the treatment. It depends upon all the etiology of acute coronary syndrome, then only we can plan the treatment, and IVUS was very helpful in assessing the etiology in acute coronary syndrome. The third, IVUS can also, HD IVUS particularly, can also differentiate between plaque erosion and plaque rupture, because treatment will differ. If it's a plaque erosion, you need only a conservative management, but if it's a plaque rupture, we need to stent it, and that can also be differentiated to some extent by high HD IVUS. This is again another example. This was a 65-year-old gentleman and a thrombolized angiography done second day. If I ask whether to put a stent or not in this case, majority of us will say no. But when we do IVUS and we see this plaque rupture with impending thrombus, I think majority of us will agree that we should stent it. So that is why IVUS can change your decision in acute MI and acute coronary syndrome also. So the fourth is, and now we have moved to era, we are doing towards a plaque-oriented PCI rather than a simple PCI. The fourth, utility of IVUS in STMI, IVUS can help you not only in identifying thrombus, particularly HD IVUS, but can also classify the thrombus and you can plan your treatment accordingly. For example, these are 3 cases of thrombus. Now, IVUS, we can say first is an acute thrombus because it's a bright appearance and sharp delineation. Second is a subacute thrombus with light to gray appearance and less clear delineation. And third is an organized thrombus because we see a homogeneous dark appearance. Identifying and classifying thrombus is important because treatment will differ. If it's an acute thrombus, we need to give more heparin or do lysis of this patient. Subacute thrombus, we can aspirate the thrombus. Organized thrombus, we need to crush it with a stent. So it will depend upon what is the type of thrombus, and we can plan treatment accordingly. And IVUS is very helpful in identifying the thrombus and classifying it and help us in planning the treatment strategy. 5th point. Will this patient have a slow flow? I am dealing with an acute coronary syndrome. We are not sure whether this patient will have a slow flow. But when we do an IVUS, we found this hypoechoic deep ultrasound attenuation. That means a very lipid-rich plaque. If you see such plaque on IVUS during acute coronary syndrome, there's a very high likelihood that this patient will have a slow flow during intervention. And this actually happened when we dilated the patient. There have been studies in which they have taken this point and assessed whether if you have attenuated plaque, and if you beforehand imply a distal filter device, the chance of slow flow will be less. This was a Vampire 3 study which has proved this point. So IVUS can help you during acute coronary syndrome to assess whether this patient will have a slow flow or not, and you can again be ready with your treatment strategy, considering that this patient might having a slow flow. Last, I can say the IVUS can give you such a detail which cannot be imagined with angiography. Third, last is, do we have the evidence to suggest this? Previously, we only have meta-analysis and short studies, but recently, of late, few months back only, we have this large IVUS ACS study, which was done particularly in acute coronary syndromes, and which classified patients into IVUS-guided angioplasty versus routine angioplasty, and which was found that there was a 45% reduction in the target vessel failure when we do IVUS-guided angioplasty, and also you can reduce the incidence of myocardial infarction by almost 37%. So now we have enough evidence to support that IVUS is very useful in acute coronary syndrome, be it acute anti-vol MI or an on-STMI. It reduces MI. It reduces target vessel failure. But this happens only when you do optimal IVUS guided. This was very important. If you do suboptimal IVUS guided angioplasty, the result will be equivalent to doing a non-IVUS guided angioplasty. So you need to optimize the result accordingly, then only you'll get the benefit of IVUS guided angioplasty.
Yeah.
I think this I can end. Thank you.
Thank you, Pankaj. Nice cases and nice demonstration of different etiologies. Any panel member wants to put some comments or questions?
Yeah, excellent presentation, Dr. Pankaj. But there are probably 1 or 2 points which we would like to know. So many times when acute MI, you get slow flow. So is there any way that you can pick up slow flow on IVUS without giving contrast?
Yeah. In IVUS, when there's a slow flow, the RBC cluster and they aggregate. So they reflect the ultrasound waves strongly. So you get a foggy image in IVUS. Contrary to normal image, you get a gray-black image, but when there's slow flow, you get a foggy image, white foggy image, because RBCs are clustered, there's Rolex formation, and which reflects the ultrasound waves strongly. That is how we can differentiate slow flow on IVUS.
One more advantage of this IVUS is thrombus-filled artery, where VCT you cannot do. There will be nothing, non-revealing. Yeah. In a thrombus-filled artery, particularly in a stent thrombosis, where the stent is totally clogged up with thrombus, IVUS gives you exactly the idea about stent expansion, apposition, and everything.
Exactly.
So it's a wonderful tool in that.
Exactly.
Thank you, Pankaj. Now we are running short of time. So let me call my co-chair, Dr. Arun Mohanty, and he'll be discussing about the role of intravascular ultrasound in heavy calcium burden patients.
Can I have my slides, please? Yeah, good morning, everyone. And I'll go straight away because this is a case-based discussion. I'll skip my initial slides. I'll go to 4 cases. This is the data about here. Now, the most important thing in a calcium is whatever algorithm you follow, the calcium scores and whatever, the basic need for before stent implantation is fracture in the calcium. You have to demonstrate, you have modified the calcium. This is an 89-year female, non-diabetic, normal KFT, SCS, LV dysfunction, surgical turndown. heavily calcified circumflex and LED, so nothing would go, so the rotablation was done. You can see nice burring of rota, just point, with reverberation everywhere. But if you come to the ostium of the LED, there is a calcified, nasty calcified looking, dull looking calcium nodule. So we knew there was nothing happening with the rota also. It was done 2 years back. So cutting balloon dilatation was done, adequately prepared. We demonstrated calcium fracture all around. You can see fracture, but the nodule remains the same. There is a opposite wall is absolutely intact, normal. So we did 2 stents were deployed, 3 into 38 giants and 3.5, 18 giants in the proximal overlapping 3.5, 15 millimeter NC balloon dilatation was done with high pressure dilatation. After proximal dilatation with 3.5, there was a nasty perforation happened exactly the area of the nodule, because the other wall was compliant, it just gave away. So we realized that immediately the patient was hemodynamically managed, tamponade was tapped and a graft master was put. Fortunately, the left main and circumflex were arising separately, so it was not required to jail the circumflex. We are lucky in that sense, and the patient was rescued. The message is, if you have a calcium nodule, you have to use either an orbital, which was not available then, but you have to prepare that and don't aim for the best area in that area. You may have an eccentric opening and 8 millimeter ostial LED is not bad, and one should not chase. The other areas were definitely much more better, but that was the lesson I learned from this. This is a case 2, where this is a diffusely diseased LED. A graft was given probably to the LED which has occluded. It was a vein graft. Lima was not, and Lima, if you see, the Lima was given to a capillary, probably not doing any purpose, and the RCA graft was okay. So we planned for a LED angioplasty. Nothing would go. The imaging catheter fails to go. So if you have any uncrossable lesion with a IVUS catheter, the straightaway thing is you have to modify the lesion. If you are not seeing much of calcium on the fluoroscopy, maybe you are dealing with a nodule there. So this was the story. You can see a nasty nodule was sitting in that area, which was not allowing us to do anything. So a rotablation with 1.5 millimeter bulb was done. It was modified perfectly, and then cutting balloon Wolverine 2.5, 15 millimeter is done. Post balloon dilatation with Wolverine, you can see it's a diffusely diseased artery. Without imaging, you just imagine what length stent you will put and what size stent you will put in this LED. So nothing is, you don't get any clue on angiogram. So we did an imaging. You can see there is a nice distal landing zone, 2.2, which will definitely accommodate a 2.5 millimeter stent at least. The lesion is well prepared, and the length was coming to 76 from left main. So we put two. Now look at the stent. The IVUS was not going, the stent is going so beautifully after preparation, adequately image guided, and 2 overlapping stents were done, and the final result also was really, this was the baseline, and you can see the LED is so beautifully reconstructed. One cannot imagine such vessel will turn to this, and this is possible because of image guided preparation of the bed, and you can get areas like 6.17 distally and proximal 10 millimeter and left main of 12 millimeter. This is another patient, a very simple looking case, and similar thing, our IVUS catheter would not go, so we did a 2.5 millimeter gentle dilatation first, then Gadzilla assisted IVUS was done, and one can see there is a type 4 nodule here which was not allowing us. So we did a OPN balloon dilatation with 3 into 10 millimeter. One has to be very careful while doing a OPN high pressure. You should undersize your balloon. Don't mesh through the distal area because you have more chances of perforation. So undersize, because the area of interest is a calcified narrowed area. So 3 millimeter OPN is a very good balloon to do that. We did that with a Wolverine cutting balloon 3 into 15 millimeter. One can see the calcium is fractured on one side and the vessel is compliant. At 3.5 into 16 millimeter synergy was deployed with a very good result. Though it was an elliptical opening, but its area is 11 millimeters, doesn't make. So ellipticity is not a criteria to for stent failure. The area is most important. This is the last case of ultra low contrast. Angio was done somewhere else. Creatinine was 1.8, 78-year female, and the angio was retrieved from the mobile, and you can see the left system was unrevealing, and the RCA was having a tight D plus IVUS, rota was done, and with guide plus the OCT was done, saline OCT was done. You can see the saline OCT run. There are tons of calcium here, which is been modified with rota, you can see, and the same thing is shown in the IVUS image also, rota polishing, and there was less of calcium fractures, so we used a IVL 3.5 into 12 millimeter. You can see the IVL balloon initially not giving away 4 atmosphere, but it inflates with more delivery of pulses. Then Wolverine 3 into 10 millimeter cutting balloon dilatation was done. In between, the patient had a short asystole with hypotension, so always it's good to give some amount of contrast to see whether you have caused a perforation or the vessel is flowing or not. So 3 ml contrast was injected in between. And finally, you can see there are multiple calcium fractures, and which has been demonstrated in both IVUS and OCT. This is not necessary, but we had opened IVUS on the table, so we checked in both. But the additional information IVUS gave us, which was missed by the OCT, was an ostial hematoma, a large hematoma lying on the ostium of the RCA, and which was missed by the OCT because of the ostial locations are very poorly imaged by OCT. So this was the additional thing which was very important, and it was covered adequately with 3.5 and 48 millimeter synergy stent. And the final result was with 5 ml, 7 ml of contrast, we could manage a rotatripsy of RCA with minimal contrast, and the area was 10.57 and 12 millimeter subsequently. To conclude my talk, angiographic severe calcification leads to underexpansion of the stent and higher TVF rates. In presence of angiographic severe calcification, an algorithmic approach to using IVUS or any imaging guides you better lesion preparation for optimal therapy. Device choice depends on your IVUS findings. Calcium fractures and nodular debulking is the crux and should be identified, and fracture and modification is the crux to good result and optimal stent expansion. Thank you very much.
Thank you, Arun, for a very
So you
nice...
are all welcome to this beautiful conference. One of the course director is here, Dr. Vijay Kumar. This IPCI 2024 to be held in Delhi. So I welcome all to this conference between 9 to 11th August to be held in Delhi. Thank you.
Thank you, Arun, for taking us through journey of IVUS and calcium lesions. One question to you is, there is a lot of controversy about presence of reverberations after the rota. So what does it signify?
Yeah, reverberation is a marker for modification of calcium. Doesn't mean you modified enough to be cracked or not, but it's a marker you have modified the calcium. So hopefully if you are modified the calcium less than 500 micron, which has been correlated for any OPN balloon or a NC balloon to crack it, that's the way you should go about.
One question.
One more here. Sir. So what is your take on eruptive versus non-eruptive nodules?
Yeah, that's a very valid topic. Always we discuss in all conferences. Eruptive calcific nodules are not a problem. They are problem for acute coronary syndrome because there is a thrombosis on the top, and they have a lipid biologically active core behind them, underneath them. So even if you modify, it's easy to modify, easy to ablate. You do a NC balloon many a time and the eruptive calcium nodule will disappear, and you put a beautiful stent, come with a good lumen area, but the recurrence rate in an eruptive calcium nodule is very high, and the recurrence within 6 months, because it's an active biological volcano which will grow inside the stent, and stent failure rates are very high. But non-eruptive, they have a very solid calcium rock on the bottom. If you don't modify, you will end up in a stent under expansion with non-eruptive calcific nodule, and many a time you land in a D-safe or non-circular stent opening, but the area of the stented area at the eruptive nodule should be good so that the event rates are low.
One last question.
Yes, sir. I want to ask one question. Because in your various calcium modification technique, it's based on the IVUS imaging, but in some cases we're not able to cross the IVUS in our first attempt. So how we decide which strategies we are going to apply on that case?
You see, balloon uncrossable, you have to do rota or rotational atherectomy. Many people have tried excimer laser also, but laser is a very poor tool for calcium. It's not a good tool. If you have a fibrotic non-crossing lesion, laser may work, but in a heavily calcified lesion, you may not do anything with laser. But rota is very handy in those cases. If you can put the wire, track your wire down the lesion.
Vijay Kumar, and he will be talking about the role of intravascular ultrasound in left main bifurcation lesions.
Thank you so much for the organizers for the opportunity. I'm going to show only one case, 64 male and traditional risk factors, preserved LV function, positive stress test, some left main disease, distal left main, some osteal LAD and a tight LCX osteal stenosis. So that's what angiogram showed. So how did we plan this lesion? So it is appeared like a mild distal left main disease, non-flow limiting LAD disease 101. And significant LCX osteal and some OM disease. The plan was we thought we assess left main to LAD, and if the LAD lesion is non-flow limiting, provisional PCA to left main to LCX, and extend to the left main, stent to the left main ostium. If the LAD lesion is flow limiting, and there is planning for left main bifurcation PCI. Why I was for left main PCI? If you take any subset in coronaries, left main is the only subset. There is a hard outcome improvement, that is mortality reduction of 4 to 7% with IVUS usage. Where does it help? And more helpful in distal bifurcation, particularly when used to stent strategies. And we all know distal left main is not an isolated disease. It is a complex involving distal left main, LAD ostium and LCX ostium. Rarely is an isolated disease. And how do you plan one stent versus two stents? And there is an IVUS rule. If MLA is less than 4 millimeters square and plaque burden more than 50%, it should end up with a two-stent strategy rather than a single stent crossover. So how did we do? 7 French femoral access and LAD IVUS pullback was done. This is LAD IVUS pullback. So what did we find? And you just see that LAD lesion is hemodynamically significant, area 3.5, and your plaque burden is 70%, so it is a two-stent case. And this distal left main, as expected, unexpectedly it showed a major plaque burden here in small lumen area. Second, it shows it is a complex rather than a single segment disease. And there is some calcium in LAD, so we needed an NC balloon preparation. We measured the length, and the stent sizing is about 3.5 to 38, and a part balloon of 4.5. All this information from LAD pullback. Dilated a LCX with a 2 millimeter balloon, did a pullback, and this is what we found in LCX pullback. And again, it is about 3.5 to 4 millimeter vessels, similar size vessels. And close to the ostium, there is most probably a bit of an organized thrombus. So we decided against dilating this part. So what is the plan here? And no dilatation, further dilatation, and 3.528 taking into consideration Coulthard stenting strategy. And this is what we did, and 3.5 NC balloon preparation for LAD. We found some calcium and stented 3.528 synergy stent from LCX to left main 0.5 to 10. That is what we predicted from pre-IVUS imaging. This is after part. And we just crossed the next wire into LCX, and angiographically it appeared to be a distal crossing because it is close to carina. And how do you identify whether the wire is crossed distally or proximally? This is supposed to be a proximal crossing, and this is supposed to be a distal crossing. When you have distal crossing, the wire should come back into main vessel stent close to the carina. If it is close to the carina, it is distal crossing. If it is away from the carina, it is proximal crossing. So this is what we found in the IVUS image. You can just see here. You can see the moving images here. And this shows the typical distal crossing. Wire comes very close to the carina. Okay, so then again I was confirmed a distal crossing. So went ahead and prepared the lesion, 3.5 preparation, and 3.538, that is what we planned earlier, extending up to the ostium. And this is what we got after stenting, and you repeated part, 4.5.8. And again, L6 crossing close to the carina, that is what you need for Coulthard stenting. So similarly, you just identify the distal crossing, L6 wire crossing. You can just see that it is very close to the carina. The wire come back into the main vessel state. Again, it is confirmed that distal recrossing of the wire. Then again, it was dilated with a 3.5 balloon, 3.5 in LAD, and the distal LAD stent was optimized with a 3.5 balloon. And the kissing was performed with a 3.510 and 3.5.8 NC balloons at 12 atmosphere. And again, part was repeated with a 4.5 balloon at 20 atmosphere. So now what you had to see, the final IVS imaging under expansion, malposition, geographic misdissection and longitudinal deformation, very common in left main subset. Standard and expansion, not going to detail, just expect anything more than 70% of reference or the areas of 6, 7, 10. Now the areas again changed now, but at least more than 90% of the distal reference, that is what you are expecting. Malposition, you don't want to have any malposition in the left main to prevent abdominal wiring. But as usual, any malposition more than 400 mics and more than 1 millimeter in length needs for the treatment. Geographic miss. So any distal edge plaque burden of more than 50% and reference lumen area less than 4.5 millimeters square within 5 millimeter of stent edge needs additional treatment. And edge dissection, routine definition, medial extension angle more than 60%, length more than 3 millimeter. If you find any of these things, then you have to fix them. This is the pullback from left main to LAD. What did you find? And there is well expanded stent. You can just see that it is more than 90% of your distal reference, no significant malposition. Left main ostium is nicely covered with minimal protrusion in the aorta. There is no significant distal landing zone disease or distal landing zone dissection. There is no significant tissue prolapse, no longitudinal deformation, and no significant neocarina. So that is what you saw in left main to LAD pullback. And did an LCX to left main pullback. That is what we found. Again, well expanded stent. There is no significant malposition and no significant distal landing zone disease or landing zone dissection. There is a little tissue prolapse, but the lumen area is very, stent flow area is very good. So no, doesn't need any further treatment and no significant neocarina. And this is what you got with the final result. Okay, how did IVS help in this case? Medina 101 angiographically become 111 after IVS imaging, and provisional stenting strategy has become a two-stent, elective two-stent strategy. And further, IVS helped in lesion preparation, LAD calcium, which was prepared with the NC balloon, L6 attenuated plaque but thrombus, so we didn't do further preparation, and it helped in device sizing and stent recrossing through the appropriate still and stent optimization. Thank you.
Thank you, Dr. Vijay. A nice talk. Do you decide about the strategy based on your IVS, whether you want to do a decay cross or a Coulomb anytime of this kind of decisions based on IVS imaging? And second question is routinely asked, there is this debate goes on and goes on after EBC main and other thing, whether you routinely do a kissing balloon dilatation of circumflex ostium if it is a provisional crossover. Left main LAD.
Yeah, the first question, you can decide the strategy between whether if both the vessels are similar size or dissimilar size, and the remaining decision is based on your angiographic angle. So whether you do a T-stenting, tap stenting, or QLAT or crush. And again, it is an operator preference, whichever stenting strategy you are good at. Most of the cases, you can do any of the two stent strategies. And the second question is, we routinely don't do kissing balloon dilatation. We just, unless it is a significant compromise of the side branch. Routine opening of L6, we don't do it routinely. Because there is no hard evidence for a routine balloon dilatation.
Yes. Last question. Yeah. Please take the mic.
The dedicated bifurcation in this case also?
Yeah, we could have used if it is, if you have a good sizes, appropriate sizes available, you could have used a dedicated bifurcation stent.
Sir, in your talk you told that when mala position is more than 400 millimeter or more than 1 mm, it is always or on the ostium of the vessel.
And left main, any malposition should be corrected in left main.
But
Whichever identified by IVS imaging, that should be more than 200 mics. Because IVS detects any malposition which is more than 150 or 200, that is what the resolution is. So any malposition you identify with IVS in the left main, I think better to fix it.
It is only for left main or any ostium?
And any area, if it is the current guideline says, consensus statement says anything more than 400 and a length of more than 1 millimeter. Particularly the proximal edges, you don't want to have any malposition.
Sir, second point. Yesterday also we were discussing whenever we are putting crossover stent from the left main to LAD in such a scenario. For the side branch like LCX, should we do the low pressure kissing balloon dilatation?
That is already discussed.
It's a debatable thing, but no clear cut guidelines. If anyone can highlight the things, then it will be better for us.
Yeah, it is, unless there is a significant compromise, we don't do routine practice, but the
If
practice
the
differs.
distal LCX is having more rate
Yeah,
of
we are
severe disease in the
running
distal.
short of time. We're running delay.
Thank
So
you.
we'll
Thank you
we'll
for
take
this
the next speaker. Dr. Vijay, why don't you join us on the join us? Next speaker is Dr. Sajan Narayan. He's a walking encyclopedia on trials and other thing, putting and enlightening every day to us. So Dr. Sajan Narayan will speak on last clinical trials on IVUS, 10 trials maybe.
Good morning to respected chairpersons and colleagues. In the next 10 minutes or so, I will update about what are the current IVUS trials. So in the last 6 months or so, we have two large meta-analyses that has been published, one in November 2023 and another in April 2024, which has conclusively shown that if you perform an intravascular imaging guided intervention, you reduce all the endpoints, including the hard endpoints when compared to angiographic guided PCI. And if you see most of the trials which has been including this meta-analysis, majority have used IVUS, few have used OCT. And the inclusion criteria in these trials have been primarily an all-comer populations, heterogeneous populations. So a doubt remains in the minds of interventionalists whether hard endpoints are, the results are replicated in complex scenarios like complex PCI according to current definitions, patients who have left main, patients who have ACS, whether these results are replicated. So we have answer in last 1 year or so where we have included, we have published a few trials. I will concentrate on that. So I was in complex PCI. So AVO trial was the first study that actually looked into what is the benefit of IVUS according to current definition, the complex PCI according to current definition. I found that if you perform an intravascular ultrasound guided PCI, the minimum luminal diameter is better when compared to angiographic guided intervention. And in IVUS XPL, patients who needed long stents, that is more than 28 mm, at both 1 year and 5 years, the IVUS guided PCI was superior to angiographic guided intervention. And in ultimate trial, both at 1 and 3 years, in an all-comer population, the benefit of IVUS guided PCI was superior to angiographic guided intervention. So in this background, the important trial that was published in last year, that is Renovate Complex PCI, which has randomized patients with complex lesions according to current definition in 2:1 fashion to imaging guided versus angiographic guided PCI. And in imaging guided arm, 73% of the patients underwent IVUS. And these were the optimization criteria which is according to the latest standards definitions. And most importantly, all optimization criteria was met in 55% and stemmed optimization in 45% of cases. And at the median follow-up of 2.1 years, composite of death, target SLMI and clinical driven target lesion revascularization was significantly reduced in imaging guided arm versus angiographic guided PCI. And when you see the subcategories, all the lesion subsets, especially CTOs, unprotected left main, severe calcified lesions, where the intervention is commonly used in imaging, the benefits were striking. And this has shown a very important message that it is not enough that you perform an imaging guided intervention, you should strive for the optimization standards. Then only the benefit is more striking. And a left main subset, that is about 12% of patients in randomized complex PCI had left main. And when you perform imaging guided PCI, you reduce the hard endpoint of cardiac death, which has been seen in previous registries and small studies as well. And this benefit was seen whether you use procedure-related MI as a variable or not. And what is the relevance of standardization protocols, which we often see in the trial, we often see in the meetings that has been mentioned. For that, the Renovate Complex PCI investigators randomized, they included the patients included in this trial and compared with the historical cohort from Samsung Medical Center, and they fished out patients who underwent imaging guided and angiographic guided PCI, where the optimization protocol was not in place, and classified this as past group and compared with the Renovate Complex PCI group, which is as a present group. So you can see that there is no difference when you perform angiographic guided PCI versus past versus present. That is, even with the improvement in the PCI techniques, improvement in the stent designs and post-dilatation protocols, the angiographic guided PCI has remained where it was. But when you perform imaging guided PCI according to latest optimization protocols, you reduce the event rates to minimum possible. Now we'll come to IVUS in acute coronary syndrome. This has been found in ADAPT-DES sub-studies that there is a gradation of benefit according to the risk profile. In the highest benefit of imaging guided PCI or IVUS guided PCI is obtained in STEMI patients. And in two studies, that is core AMI registry and meta-analysis, found that across the different categories of ACS, the benefit of imaging guided PCI remains. In this background, IVUS ACS trial was been randomized all categories of ACS. And most importantly, 97% of the patients were randomized for emergency room when compared to previous studies where they were randomized only after 24 to 48 hours after presentation. And these are the optimization criteria, and most importantly, the IVAS optimization criteria was achieved in about 80% of cases, which is highest among the studies that has been published in last 2 or 3 years. And at the end of 12 months, the cardiac death, target vessel MI, and clinical target lesion revascularization was significantly reduced in favor of imaging-guided intervention. And also, this also gave a same message as Renovate complex PCI investigators, that if you perform on optimal PCI, the event rates are lowest. And also, this showed some light into what were the causes of suboptimal PCI. You can see that the most important reason for suboptimal PCI was landing in the stent in an area where the high lipid patch, or you are not achieving adequate expansion, which are the areas to improve when you perform imaging-guided intervention. And Renovate complex PCI also looked into this aspect, whether there is any heterogeneity of benefit with regard to the presentation, and found that there is no heterogeneity. Both groups derive same benefit, and major driver of MACE events in patients who are on ACS was reduction in cardiac death, and major driver of reduction in events in patients with stable angina was reduction in procedural MI, primarily because of the difference in the risk profile of the patients involved. And the benefit of imaging at optimized PCI was more striking in patients who had a clinical presentation as ACS when compared to CCS. Now, lastly, there is a debate, what is the optimal MSA criteria in patients who underwent left main intervention. Historically, we have been using a CAN criteria, that is 5, 6, 7, 8 rule at segments of distal left main, where it has been shown that 9-month angiographic instant resolution is lowest when you achieve these events. And this was superseded by Excel trial, which looked into the clinical endpoints, and the cutoff was 10 millimeters squared to reduce the MSA. Hernandez et al. Looked into another criteria, that is relative criteria, that is achieving MSA of more than 90%, and when you achieve that, the event rates are lowest, that is 4.8%. And absolute MSA in this study was 11.8, 8.5, and 7 in left main, LAD, and circumflex respectively. But this is very difficult because we know that in left main, most of them are diffusely diseased. You don't have a reference segment to compare with. In this context, the same investigators who put forward the 5, 6, 7, 8 rule looked into what is the optimal MSA in patients who undergo at least 2 stent strategy, predominantly crush strategy, and its variants, that is balloon crush and conventional crush. And they included patients who had underwent this strategy between March 2005 and December 2019, true bifurcation lesions, and looked into a follow-up of 5 years, and looked into which are the optimal MSAs that predicted event rates. And the optimal MSAs that is associated with the reduction in MSAs were less analysis. There is a gradual reduction in the MACE rates as the MSA of the circumflex. You achieve the distal circumflex MSA of more than 6 millimeters squared. The MACE left main, the MSA at LAD and circumflex OST are equally important in improving the outcomes in left main. So in short, IVAS optimized PCI something higher, and IVAS optimized PCI is feasible in ACS and improves outcomes. Thanks for
doing imaging is not enough. You have to do optimal imaging, meeting the criteria. Anyone
to class 1 in any of these guidelines? No?
Actually, currently we have only class 2 recommends, but I think in some guidelines that probably ESC may come out with some guidelines in next month. Probably we expect that it may be upgraded to class 1 at least in left main and complex PCS because the evidence is highly compelling.
So, any comments from audience?
Yeah,
or the
Dr.
panel?
Sajan, do we have evidence that in non-complex subsets, IVAS is useful in routine day-to-day angioplasty? In non-complex subsets like non-left main, non-ISR, non-CTO, non-calcium?
Actually, if you see the earlier trials, the evidence, whatever evidence that I have presented applies to all the subsets. When you have complex lesion subsets, the evidence, whatever benefit is, you see it much earlier in the studies. But for non-complex PCI, if you perform a study, you need a larger sample size and longer follow-up. So, but there is no heterogeneity with regard to the MACE rates events observed across the lesion subsets.
So, thank you, Dr. Sajan Narayanji, and welcome Dr. Nishi Chandra for the last presentation of this session. This is a live in-box case, interesting case. Let us discuss and hear it from Dr. Nishi Chandra. Thank you.
So, thank you, Dr. Arun, and good morning, friends. I was to present a live in case box, but I recorded a case, but a much more educative case cropped up. And I thought, let me take this case as a teaching case for this. Now, I'll stop it between and ask the audience and the panelists, what should we do? So this is a case there, the 5-day curse. Now, what is, despite all this evidence as told by Dr. Sarjan, there are lots of, the uptake of intravascular imaging is very, very low. Even in the United States, it's only 10 to 11%, and in our country, it's less than 3%. The commonest myths or the barriers in taking this intravascular imaging is, the commonest is, I am an experienced interventional cardiologist. My results are very good even without imaging. Why should I do imaging? Second, it's expensive. It comes at a cost. It takes time. And third, there is no data. Now the last one is already shattered by the humongous data in favor of intravascular imaging as told by Dr. Sarjan Narayan. Let me take the other three one by illustrating a real case which happened in the last months in our hospital. So on 27th of May 2024, a 65-year-old gentleman came to our hospital, diabetic, hypertensive, previous standing to LAD many years ago, with a 3 hours history of chest pain, and he was having acute inferior-posterior wall MI on the ECG. The ejection fraction was 40%, and patient was taken for an angiogram rightly in our hospital. And this was done by one of the most experienced interventional cardiologists with more than 30 years of experience under his belt. So this was the left system. You can see the culprit vessel, which is circumflex. This was the RCA, and this was the LAD. So the culprit was circumflex. They were doing it primary, so they had to treat the culprit vessel. So they treated. Now they just first wired it and they restored the flow, and this was the image. Now, what should be done? My esteemed panelist. In this case,
I would try to negotiate the imaging catheter to take a IVUS image to see what's happening in the ostium on the left circumflex, how much is the left main and distal, the mid circumflex. There is an instant lesion, and finally distal to the stent there is diffuse disease. I would rather like to follow up in medically. There is a OM ostial disease, so maybe a drug-eluting balloon or something, if it is significant, it looks significant and the vessel is really sizable. So this is my initial plan. Anything from any pen?
Any other? So how many of you would do imaging in this case? So majority are in favor. But in our hospital, one of the most experienced center, most experienced interventionist, the imaging was not done. So now what size stents should we put? Now lots of centers have no privilege of imaging around the country. But what stent size should we put based on an angiogram? 90% of the angios are done, plasties are done in our hospital, even in US, just based on the luminogram. Panelists. If this was the angiogram, what size stents would you put?
So that's a 6 French guide, isn't it?
Yes.
Yeah, okay. So probably I think 3.5 stent and 4 NC will do for this case.
So 3.5.
3.5 stent and 4
distally?
NC.
Distally?
No, distally, of course, see, what I am talking about is
Here.
just probably near that OM or just after the OM. And distally, of course, it is going to be around 3 or 3.25. That is how it looks on an angio. But probably my estimation might be different because we regularly do too much of imaging. Probably you should ask somebody who really doesn't do imaging, just take the
Anybody
angio.
is comfortable putting a 3 millimeter here?
Have we done adequate vasodilatation, nitroglycerin and thrombosuction? Because it looks like
So this,
and dissection.
yeah, so this was after restoring the flow by thrombosuction now. So,
2.75, sir.
sorry? 2.75, okay. So there was some agreement. So the stent which was put in after pre-dilatation with 2 and 2.5 millimeters, and those who are not, who don't know about the biomimorph, this is basically a cobalt chromium stent, with a tapered morphology, especially for long tapering vessels, and with 65 microns strut thickness ceruminous coating. And this was put here, post-dilated.
Was it, easy to put a long stent distally through a
Yes,
existing
it
stent?
was actually...
It was guide extension.
Yeah, it negotiated well in that. And it was post-dilated with 27512. And because there is a previous proximal lesion in the circumflex, so the operator decided to put Onyx Frontier stent 2.75 into 34. So this was the result on the index case, the angiographic result. Patient was discharged on regular DAPT, hydrostatins, beta blockers, anti-diabetics. So far so good, but the 5-day curse struck. 5 days later, the patient again came back. This was on 1st of June after 27th May, 1st of June, and this was there was a stent thrombosis. Now what should we do? Again to our center. What should we do now? So the operator decided to do a POBA of 2.5 balloon and followed by 2.75 with this result. 5 days curse struck again. After 1st June, 6th June, he came back with the same stent. And this time landed up with imaging. So IVUS was done, and you can see, this is a long run, so at that point, you can see the stent was only, MSA was 2 millimeters square. And the distal, it is 3.8, proximal 5.77. So 2 millimeter square stent was, MSA was left at one of the most experienced centers. And so what should we do now with an imaging thing? We should know the underlying vessel size. So these were the underlying vessel size. Here, the vessel size was 3 millimeter. It's very difficult to put a 3 millimeter stent just based on an angiogram. Here, the vessel size was 3.9 and the proximal was 4. So based on these data, then we took a cutting balloon, dilated it well, dilated with 2.75 NC balloon, and finally took liberty of OPN 3/15. We dilated the biomime morph with 3 at an atmosphere of 35. But even despite that, we could see that this was the post-OPN, post-cutting. So we did another IVUS, and here you can see, there is a hematoma here, and here what can you see here? In this, can you see the stent struts anywhere? So the biomime morph got fractured here. You can see it very clearly here. These are the long views, and here on this point you can see there are no struts here. And when we did the imaging, high resolution imaging, you can see the fractured stent. Now we were constrained to put another stent inside that. Fracture with hematoma, and we had to put another stent. And this time, based on the imaging dimensions, we used a 3/37 drug-eluting stent, post-dilated it well, and this was the final result on the 3rd admission of this patient. And this was the angiographic and the IVUS data. This was the point where the MSA was 2 millimeter, and we dilated it to 7 millimeters with the help of intravascular ultrasound. So these were the final results. You can see these were the earlier results, and these were the final results. 2 millimeter expanded to 7, 5.7 to 10. So these were the results. But did the story end here? The 5-day cuts. This was the angiographic image. 5 days later, what must have happened? Patient came to our OPD, nice, symptom-free, so far so good. So this case basically has shattered all the myths that I am an experienced interventional cardiologist, my results are good, even without imaging. No, you have to take help of imaging. It takes time, not if you take the time wasted in multiple admissions. There is no data. Dr. Sajan has already told us the numbers of meta-analysis, network meta-analysis, where the hardest on points were reduced. Or imaging is expensive. That is one more thing. In first hospital admission, the cost was 3.5 lakhs. Second hospital admission, 2.5 lakhs. Third admission, 3.75. Total cost for one single primary was 9.75 lakhs. So you can decide whether imaging is expensive or not. So learning points, ladies and gentlemen, is imaging is not a substitute even for the most experienced interventional cardiologist. In case of stent failure, imaging is not a luxury, it's a must, and there is no place of guesswork in 2024. I invite you to the IPCI in 9 to 11th August in New Delhi, and thank you very much.
Yeah, thank you, Dr. Nishi. That's a nice case and difficult one, but we must understand imaging is definitely handy in such cases when there is already a stent lying inside the vessel. I would definitely image the distal. I would not. Calcium is a complex lesion particularly, and putting so long stents and one after another layer is not going. In that process, they lost a major OM, and the final angio, the OM was gone.
Patient the best. You should take the advantage of imaging nowadays. Preeti.
Excellent case, sir. My only contention is that this biomime morph, with these stents, I think we have to keep in mind that somewhere in the process we might fracture our stents because they have an expansion limit. And I should keep in mind the expansion limits, and the proximal circ always look like 3.5. So I think that is the only thing which
expected that fracture. Yeah.
One last question, then we end up the session here.
Sir,
because
the final message should be in angiographically what of the size you are looking at. So I was 0.25 or 0.5 mm diameter more or what?
Yeah, usually it is more because we have been, all these years when I was not doing imaging, I was under implanting the stents. We have seen patients with coming from periphery with LED stent put 2.75 or 2.5 stent. LED is never 2.5 proximal LED. It has to be 3 and above.
And finally you lost all the OM branches.
Yes.
Any trial you didn't take to open the OM branches?
No, it was not because it was a primary situation, so we did not try that. And ejection fraction was already 30%. Dye load was too much.
See, it is not that what I understood from your question is it something like you think that you have IVUS high or OCT high? It is not like that. It varies from case to case. Although you do so much of imaging, sometimes it might be deceiving to take a decision in an angiogram. You might think that the vessel is 3.5. Many times we have seen that vessel is only 2.75. So it is not always a rule that you upsize for whatever you guess. It doesn't work like that. If possible, if it is affordable, if everything permits, I think imaging is a good option in all such cases.
Sir, one last question. What was the stent you used in the last?
So that was a 3/37 drug-eluting stent Evermime.
You have used again Evermime.
Yeah, thank you very much. Thank you.
So I invite chairpersons, panelists for the next session, whoever is available. And the speakers for the next session are Dr. Julio, Dr. Floram Kukuli, Dr. Bahulian, and Dr. Girish. So we'll start with the first presentation by Dr. Giulio. I welcome Dr. Giulio for the first presentation.
Okay, thank you so much. I'm talking about my approach to bifurcation lesion, lesson learned from October trial and imaging use. You know how much complexity you might have in decision-making inside the vessel. Could be done partially by angio, likewise a criteria definition of lesion complexity, bifurcation angle, plaque distribution, plaque morphology, and the geometrical changes are much more difficult to be highlighted with a precision by using only angio. Here you have the spectrum, incredible spectrum of a capability of imaging at a different pit stop during the procedure of the bifurcation, where they can help you in making an answer in terms of measurements, interpretation, decision-making. And we know that by angio definition, they are the criteria for complexity. Legs more than 10, calcified, thrombotic, bifurcation lesion width. Should procedural planning be part of a standard set of imaging guidance criteria? In this case, we are talking about a 50-year-old man presented with unstable angina. My answer, if you wanted to compete with mammary artery, is definitely yes, and definitely at high level of precision. The same if you are going to the opposite, very old patients presenting with this type of distal left main lesion, female, fragile, unstable angina. If you wanted to finish this way with this complex procedure, you needed to get some more information. So October, and the point was very clear. Does intravascular imaging, more specifically OCT, optimization in complex bifurcation translate into clinical benefit? A lot of instruction. They were super expert in doing this bifurcation. And you can see graphic, do this way, do this way, do this way. And then a very demanding protocol. Likewise, watch before to final evaluation and with a clear goal. Optimal lesion coverage, optimal stent expansion, no stent malposition, and non-intended stent deformation. You know every adjudication. Bifurcation with a side branch more than 2.5. Results. In the top, you can see the rate that was planning for event. 16 rate at 2 years for angio guidance plan. That was totally different compared to the Lumion 4 we were running, where the lesions were much more spectral, much more difficult, including diabetes, clinically diabetes, that was a different story. This benefit in favor of images was proven not only for the common bifurcation, but especially for the left main, despite the fact there were less patients with the left main. And it was proven for both single stent, provisional stent, and 2 stents. Let's go a little bit on the new release from October, going one by one. What did we learn about before stent implantation? That is the point. So watch to the amount of plaque that needed to be prepared. At the end, 1/3 of the cases need more plaque preparation based on the first OCT pullback. Was done only in less than 50% of the cases. Here, you have the impact of the imaging in terms of stent sizing. People say, oh, you are going to make a big issue to the vessel. You can see there was not too much difference in terms of largest balloon use, and you can see that at the level of perforation, the safety was totally respected. No significant difference. What about the phase 2? After rewiring, here, you can see what we call accidental luminal rewiring. Abluminal rewiring that can be due to many different things. How frequently it was? It was not very frequent. It was in about 5% of the cases. And they fix it? Less than 50% of these experts, so more than 45% of the patients were unnoticed with very important. And you can see an example below of different images showing an abdominal and stent deformation. Here you can see the causes of uninstented stent deformation detect certain mechanism. What we got? Mainly this one. And because the people are talking about the left main, and perhaps guided only by angio, this is very important to be kept in mind. This you can see, this type of deformation segment. Much more rare confront the unintended stent rate of unintended stent deformation in the left main up to 80% of the cases. You have a deformation of the stents and you are not treating. And you can see the clinical impact of this. Very important to have a final pullback. Does it matter? This is the answer. When you have a final complete pullback with OCT, the events are going to be significantly less if you are properly interpreting. Here you have what new we have in terms of capability for bifurcation. Here you can see how we can get some identity of the wire crossing, how we can fix eventually the right position of the wire. Why we are interested in this? Because the only bifurcation where to have a link crossing is going to pay a price is the distal left main. Here you can see that if you have a link crossing in follow-up, the lumen of the circ is going to be reduced. Key points for this analysis when you are using 3D. Overhanging struts in front of the circ, that should be avoided. And the position of the rewiring is going to be critical. And here is the target, to get adequate stent expansion at apposition in the point of confluence and minimal metallic neocarina. Can you detect by angio? I don't think so. Here you have eventually, when you are detecting some limited suboptimal stent implantation, how event should look not only to the pre, but a lot to the wire, and optimal guide wire recrossing. Here is my paradigm. And this way, if there is an ABC document talking about the value of the angio, it was published 1 month ago, and then you are going to the conclusion, intracoronary imaging is increasingly considered to provide the gold standard guided for complex PCI, bifurcation PCI, with evidence demonstrated superior result to angiography alone. However, education and access to technology remain a major barrier to the adoption of intracoronary imaging, and the vast majority of complex bifurcation worldwide are undetected with angiographic guidance alone. It's not an excuse to approach the next complex bifurcation only by using angiography system, and especially if the angio system is not super high level of resolution. Thank you very much.
Thank you so much, Dr. Julian. Great talk. We'll have a discussion at the end. I'll just request Dr. Kokuli to give the next talk on understanding from disturbed CAD trials, OCT subset.
I have a large file, so it includes a lot of OCT images.
Okay. Somebody can help in loading the slides,
No,
please?
it's going. It's just the file, which is a bit larger. I would like to cover is the role of OCT in treating calcium, and I think it's very important to realize that we are in a war for lumen. So I think we can win this war by creating a lot of lumen and by not creating a lot of complications, means especially perforations and dissection we don't cover. Now, when you think of calcium, then you think of an undilatable lesion. And I think if you encounter an undilatable lesion, that's the perfect moment to think of intravascular imaging, and then you might detect something like this. And nowadays, atherectomy, you can try a normal NC balloon if you want. You can try, some people would do a cutting balloon, and some people would do even shockwave. And this is a great situation because I think 20 years back, you didn't have a lot of these choices you have now, and you have the open NC, which this is for younger colleagues. If you have a calcium ring, then the vessel might be large, but the ring, the inner diameter of the ring is not that big. So even a small balloon can crack such a ring. So it's not always important to take the biggest balloon. The vessel was a 4O vessel. But you needed a bit of pressure. And then you end up like this. Now, it's also important to realize that even the presence of superficial calcium, you cannot modify that with normal balloons. And a semi-compliant balloon would dissect the non-calcium. The problem is that there is a lot of eminence. Some of them, for me, evidence is not just controlled registers. It's called a trial, but it's actually not a trial. It's a registry of they wanted to prove that IVL is safe, and they did. Efficacy, I'm not sure. I would have expected a bit more. And the most difficult thing is this in a randomized manner. And some colleagues from Munich did that as well. So they are doing the. And I think this trial will show is maybe the OPNNC as good as IVL. Trial which we are doing, where I am the PI, is to compare OPN versus shockwave in a big, and I will show you a case from this trial. So what we want to show is that NC balloon. This is a very courageous compete with this, but we have, of course, to prove it. This is the design of the true OCT, then we implant stents, and then we do final OCT to assess for this, which we have done recently. LED diagonal bifurcation. Here you can see that on OCT, quite a nice heavily calcified lesion. Here, rotablation. So rotational atherectomy is allowed in the trial. And then we used the OPN NC balloon because it was randomized to that. And you can treat it, DCB in the diagonal, stents in the LED, and then we repeated the OCT. And as you can see, so open works. I would like to assess and treat calcified. This is such a long disease, and the distal vessel is nice. However, the patient rejected. Now, of course, you could do many of these. Nice calcium ring, another ring, then here again more calcium. You would see that on ultrasound too, and then the distal part of the is size of the vessel, because I think this will really avoid complications. And then at 30 atmospheres, the open NC was dog boning, but at 40 atmospheres, it gave in and it cracked the lesion. Then this is what it looked angiographically. But I think even now it's important, before you conclude your procedure, to have a look on OCT, because you have it on the table. And if you look on OCT, you will see, okay, proximal part, nice, beautiful cracks. I think you are done here if you want to 5.5, which is actually quite good without a stent. And then in the distal part, here you see the MLA is 4.7. In this case, I only did one mistake. However, I did implant a stent because back then we were still not for an elective angiogram to just check, and then it looked good and the patient had no symptoms, so we saved him from bypass surgery. Now, let me conclude with one interesting case where the calcium is in stent. So in this case, you see the patient has received a stent previously, and we have the calcium in stent. And now what? In this case, we broke it again with an open NC balloon. You see beautiful, nice cracks. You create lumen. However, the problem is this is really a mission impossible to create lumen, because except, and I know Darshan will say it's off-label, but I think except you go and use orbital and remove this calcific tissue from within, then everything else is difficult. Now, I will just come to the conclusions. What I would do, what I would suggest when treating calcium, I think it's important to do intravascular imaging. I think for undilatable lesions, and calcium rings, in my opinion, open at high pressure is fine, but shockwave is fine too. In uncrossable lesions, I think rotational atherectomy or orbital atherectomy is the choice, because you have more and more as we gain more confidence. And I think in superficial calcium or in fibrocalcific lesions, then you could use a cutting balloon. Thank you very much for your attention.
Thank you, Dr. Floram. And third talk on this series is Contemporary Treatment of Stent Failure by Professor Buckley.
Respected chairpersons and friends. Now, stent failure is a challenge nowadays in PCI, and it is on the increase actually. Even with the newer generation of drug-eluting stents, we do come across at least 5 to 7% of our PCI as stent failure, restenosis and stent thrombosis. Now, as all spectrums of coronary artery disease, what's the role of image-guided PCI in these sort of situations? We have IVUS and OCT, which could be used in guiding the PCI of instant restenosis. But as mentioned in one of the lectures, it still remains a class 2A indications. It has not become class 1. Probably we will hear soon that class 1 indication comes into at least complex subsets of patients. Now, to understand the mechanism of instant restenosis is very important to have a successful treatment. We have biological reasons like neointimal hyperplasia, neoatherosclerosis, which could be calcific, as we have seen inside the stent. Maybe neointimal hyperplasia may be heterogeneous or homogeneous, most commonly heterogeneous following instant restenosis. Stent-related issues, mainly the commonest is undersizing, underexpansion, fractures, geographical disturbances of the stent, multiple stenters, or complex issues comes up in a given case. OCT really, because of its high resolution characteristics, precisely identifies the mechanisms of stent failure, guide appropriate treatment, and helps to ensure finally the adequacy of a treatment stent failure. That is how we should look upon this imaging in treating these cases. CT features of neoatherosclerosis. If you look at, we can see thin cap fibroathyroma, neointimal tissue, which is lipid-laden plaque, and intrastent calcium inside. You can see macrophages and cholesterol crystals, sometimes plaque rupture as such, and we'll find neointimal vascular channels. All these could be picked up very carefully if you look at from the OCT. So that is the importance. This may not be, especially for neoatherosclerosis diagnosis, it comes up as the first mode of imaging. And stent failure, when to perform OCT, you should have a systematic approach. As mentioned in October trial, we have now really 3 ways of looking at it. Pre-procedure, we should. What is the reason? You will find out neointimal proliferation, calcific neoatherosclerosis, stent underexpansion, fractures, and all lot of things could be made out pre. Intra-procedure is very, very important because, as mentioned, you may use the devices like maybe OPN, maybe NC balloon, maybe cutting balloon or IVL, whatever it is. At the end, you have to see the adequacy of your vessel preparation and what the lumen you have gained. Unless and until you ensure that, then you go with devices of stent, it will be a failure. And post-procedure, of course, the optimized result can be verified. That is the basis. And you will find that the stent initially was placed up to the septal perforator. Now there is stenosis. We don't know what is inside it. You will see the OCT reveals deep atherosclerosis, and there was a the stent has been placed after, in this case, because, and after the IVL I mentioned, we should have calcium over there. That is enough to go ahead with the stent, and you have the Here in the proximal portion of the stent, close to the circumflex, there is a balloon of 4 and give a dilatation. And then final result is, because we really don't know what exactly the correct treatment for in-stent restenosis and difficult, another drug-eluting stent. And the patient has come to for again restenosis. So it's a recurrent restenosis. You will find that even before the imaging is the stent boost showed that the stent which is placed is actually clearly underexpanded, the new stent. And you can see the 2 layer of stents. This is important to visualize 2 layer of stents in when you have the multiple layers, and what exactly is occupying in between the stent. Is it tissue or is it calcium? What is the magnitude of the tissue and how you are going to tackle it? So these informations are clearly forthcoming with the OCT. Here we have dilated, and then with the scoring balloon of 3.510 and followed by an NC balloon of 3.75 and checked it again. Now, reasonably good expansion of that overlapping stent has been seen. You will find that the stent boost also show that it is almost now approximated. This is to be very important to ensure that. Then what is the next procedure? Is it a stent or a DEB? Now, put in another stent and make it a 3-layer is definitely inviting problems. Soon the patient will come back to you with restenosis. So we have used a 4 millimeter into 15 DEB utilized, and this is the final angiogram. 6 or 7 months have been passed. Patient is doing okay. Now, this is another case, again, right coronary artery, who received multiple stents and has come with subtotal occlusion and acute coronary syndrome. You will find that calcific neoatherosclerosis is very well made out, and the proximal stent, you've got really heavy calcium, and the distal is heavy plaque also, distal to the stent. So this has to be analyzed, and then we used a cutting balloon in this case, followed by NC balloons, and then stented the patient with the 2 stents to cover the proximal and distal area. And OCT really helped us that the new 2 stents should not be crossing with the previously overlapped 2 stents. That information has been very well made out by an OCT run, and that is the final angiographic result of that particular patient. Now, this again, sometimes patient comes with acute occlusion. You open up and then you do it again. You find that this patient has got an overlapping two layer of stents over this thing, and you will find a thrombus very well visualized. That is a red thrombus as well as mixed thrombus. Sometimes you may have to treat thrombus-directed way of approach first, and then you dilate and then achieve the area. Here, after the Scorflex and NC balloon dilatation, you look at that, the vessel is opened up very well, and then you can place the stents. This part is very important, and this will be ensured by a good lumen size is there and not much of asymmetry, and you feel that the final angio of that patient. This is a patient who had undergone primary angioplasty for now. Stent thrombosis may be because of a undersized stent, underexpanded stent, edge. It is an underexpanded stent. Distally it is well expanded, but proximally it is. OCT really gives a lot of insight into the mechanism. Conference several times in complex PCI, intravascular imaging of patients for in-stent restenosis. I think that's important to note that. And now one more, I found that in ISR versus de novo lesions, and OCT done based on the OCT was a higher percentage, 94.2 versus user imaging, especially OCT, identifies mechanisms of stent failure, enhances better preparation of the plaque and optimization. There appears to be a lack of procedural granularity. Why? Because we have MLD max, very clear cut as to we go by. But here we have the problem. We have the imaging, we have the devices. In the treatment of stent failure is not yet evidenced by randomized controlled trial. Thank you very much.
Thank you, sir.
Morning. You can play the video, please. Good morning. It's a great honor to be here today, and a lot of discussion on how imaging and plaque modification and strategy to treat
But if you play the video.
Show you a case of bifurcation for NIC 2024. Had undergone a primary angioplasty to LED with 275 into 26 drug-eluting stent. He continued to have exertional angina for last 1 month, and the stress test was positive for inducible ischemia, and we thought we should do another angiogram. Now when the angiography is done, I would like you to focus on this. It's a osteoproximal to mid, and there's a large obtuse marginal branch which also has about 50% stenosis. So with me in the cath lab today, then Samuel Sakaria and Dr. Mahalinga, anesthetist. Since this is an elective case, we would like to do a standard simultaneously, and you can see how we wire the first one, because whenever you engage, the guide is going to be larger than the coronary artery. And then go to the next view. The guide is directed towards the ear, and then now we would like to prepare both the lesions to do an IVUS. It's although you expect some drama, left main to circumflex, left main OCT either. The greatest advantage is you understand anatomy or the structure of the vessel as well as the plaque constitution even better. The lesion, agree block 8 ml. This is all lipid rich. You can see almost like a thick fur. Give me a cutting balloon for the LAD if you have 275. This place where there is significant tissue grown inside and some under expansion of the stent, which was done during the MI. Probably there. So about 3 mm stent it would take the proximal LAD easily. So that's why we're taking 275 cutting balloon. That's the circumflex ostium. It's reasonably large, but look at the diameter in the left main. And come back frame by frame. It looks very fibrolipid rich, and there are islands of calcium but not too calcified. Whenever you do a dilatation of the cutting, a good location, freeze, yeah, go. Going. I think we got a great expansion of the previous stent here. So now we don't have osteo left main dampening anymore. Hemodynamics looks good. Okay, so we have a very good large opening. So now we're trying to use 3.5 into 10 Wolverine cutting balloon to get a nice cut on the left main lesions. So this is a great dilatation into the left main. Pressures are good, no dampening. That's because there's a good cuts. Go 1, 2. We'll do a T-stent. After pre-dilating the left main and the circumflex ostium, we'll redo the OCT just to know how well we have expanded, what is the luminal gain, and what is a plaque in true sense. Start. Okay. What all we need to understand with this OCT? What is the length of the lesion that we need to cover from proximal circumflex into the osteoproximal left main? What is the diameter? How much of the plaque we have modified? Are we satisfied? And what is the LAD opening looks like? So we would take 418. We'll take Zines Sierra. This is the most contemporary Zines platform available to us. Our experience with this in the recent past has been exceptional. Its trackability, conformability, its precision in positioning has been amazing. And the best thing is its ability to be post-expanded to up to 5.5. Any platform more than 3 millimeter in diameter of Zines Sierra can easily be expanded up to 5.5. We just thought, if you really want to look at the left main ostium in a situation like this, having a guide extension catheter which engages the left main alone better and directs your contrast selectively than the guide. Perfect, I think. We're happy about the position? Yes. Here you can see we are trying to position the stent at the ostium of the left main, not only with the help of guide but also guide extension catheter. If you see how we are positioned, we are trying to bring the Zions Sierra stent to the ostium. It's the simplest stent to use in such situations, you know, because the stent starts bang on the middle of the dot, so you're 100% certain where the stent starts. So we shall do the pot with 5.5 into 8 millimeter NC balloon. We seem to be in the ostium of the circumflex. Excellent. Go. Ostium of the left main and circumflex, we are going to dilate with this. Now it becomes important to wire the LAD. If you can see here, my guide is already sitting inside the stent. This is the beauty of this Sierra stent. You can see there, we are in the middle of that LAD vessel, and nicely we can do provisional stenting in this. Let's try. I have not opened the struts of the left main to circumflex stent, and we are taking a 312 NC balloon directly. We open the side struts from the left main into the LAD with a 3 into 12. Good, wonderful. Now we are taking 3 into 8 Zions Sierra as a T-stenting strategy. Yes, this seems excellent. We take the 3 NC balloon and finish with pot and get out. So we're done. Let's do the pot and then we'll do a DCB to the distal vessel, and we do OCT after that. Normally there is some stent foreshortening that happens, but for Zions Sierra it's a 5.5 diameter slotted, absolutely 0% foreshortening. So then you know stent is going to remain wherever you are positioned. Let's dilate to the 5.5 millimeter away from the carina. You can see here the OCT clearly shows. I think here we need to change a bit of strategy. So I need to crush the stent. Go back. There's so many struts there across the origin of the the provisional T. Everybody says keep doing provisional T. Whenever you do a provisional T stenting, there is extra reverse crush like therapy for this, and we'll recross. We are crushing all that metal that was, and now let's go and cross it from the distal part so that I can compress rest of the metal. It looks amazing. That is the LAD, okay. That's a neo carina which is coming. Now there are no struts across circumflex. Start. Back into the left main, from circumflex back into the left main. What it shows is the limitation of T-stenting. We think it's the safest, and to avoid two-stent strategy, this is one of the most common bailout strategy, but it has its own limitation. When you put a T-stent, when it's not absolutely perpendicular, there tends to be extra metal hanging into the main vessel. If you do not crush that and again recross, you're going to leave behind a lot of struts across the main vessel. So here, we clearly demonstrated that when you do it from the left main, the lower part of the stent is always prolapsed. So what did we do? Upsized the balloon by about 0.25, took a 4 millimeter balloon from left main to circumflex, crushed that prolapsing part of the stent, and then recrossed into the LAD through those crushed part, and then crushed that LAD stent. It was like a reverse. We normally don't recross or image after DCB, because it may alter the drug delivery. Thank you. Hospitals, Banagata Road, Bangalore.
Yeah. Any comments from our moderators and discussions?
In your case, I just want to know what was the MLA or osteal LCX?
It was quite large. You could have asked me whether should you just stented crossover left main to LAD.
Yeah.
The thing was main was towards the circumflex, not for the LAD. So that's the reason we chose to stent the circumflex, not into the LAD.
I just want to have a question for Giulio. So you presented the October trial, and it was obviously very positive in verification, PCI as well as your imaging. Do you think that's consistent with real-world practice?
To rethinking, if you watch to the amount of contrast, to the lengths. So the fact that we needed to go back and absolutely simplify the step-by-step approach and right again, we don't have education and we don't have enough money for supporting what should be done. That is the opposite side that we needed to go. And in my view, there is a lot of attention that needed to be spent more in refining and simplify the procedure instead to go back and say, well, it's difficult, it's not achievable for everybody.
Giulio, another questions. As in other studies like Ultimate and IVAS XPL, do you have any data on when you achieved all those criteria, what is the event rate, that analysis, anything has been performed in the study? You achieved all the parameters, the parameters of stent optimization, what is predefined in the study. Do you know what exactly is the stent failure rate?
I don't have this data. And we needed two aspects. One is the role to get a final pullback. That is very, very relevant, because if you are missing the abluminal wire position and the stent deformation, I think they are going to get a significant impact on the patient's outcome. So that is a crucial point. And that is a matter for adding education also to the expert, because if in only 50% they are able to detect stent deformation.
About the carina tip to branch point length, because deciding our strategy is one thing which we are still not doing on OCT or imaging. Means we are using it pre-procedure, post-procedure, during the wire, but deciding the strategy is still an area of interest. So any thoughts about the length that is discussed, carina tip to branch point length?
Okay, two different things. Number one, the evaluation of the procedure, and you needed to understand what should be done. In the post-procedure, we got an example. Sorry, Dr. Navagun. If you are watching to the cross-sectional view, this carina was not neutral, was displaced. And that is the additional value also for the 3D stent for getting better the position of the carina and eventually go back an alternative delayed again input that we still need to implement in our technology.
One question, you have in the bifurcation, the OCT rule has been clearly getting established. Single stent versus two stents of complex procedure. Do you think that it has got the same value in treating bifurcation?
So surprisingly, in October, it seems that there is more benefit in a single stent than in a dual stent. In my view, is because the dual stent is much more difficult to be interpreted, also by the expert, and you saw how many times they miss a crucial point. In which way the provisional understand distally, but also proximally, because many times the left main is no cylinder, so malapose strut. So you needed to take the right measurements.
So I have a quick question to Dr. Baluian. Sometimes when you have really terrible neointimal hyper,
to get a good,
do you restent, do you use a DEB?
Mechanical problem is there, and then after preparation of the neo-intima, you get a good, a fairly good size. It does is accepted as strategies. Comparing these two, probably does
cases of ISR, especially if they are associated with a stent fracture, I think
one has to go by a stent.
those are situations where we should mandatorily use a DES again. Yeah. And if we don't see a stent fracture and if it is a purely a biologic phenomena, then the DEB may have a role. Yes. I think so. There's a recent classification and heterogeneous, but even amongst experts, the inter-observer layered. So this classification actually helps us define the stent struts beyond that tissue.
Any questions from the audience? Maybe one final question will conclude the session.
Dr. Kulkuli, exactly whether you are using to IVL in the open balloon randomized control trial, so how often you are going to IVL, because you need to have some amount of time there, so you are going to block your left main.
So the question is IVL or OPN in a calcified left main?
Yes.
Well, yeah. For me, it's always clear. I always use the OPN first and then escalate to IVL. For me, IVL is an escalation therapy, not a first-line therapy. But I know I'm an outlier here.
Now, in your control trial, you are going to have a trial of...
Not exclude, no.
So even if in left main you are going to have IVL?
Yeah. I mean, if you do IVL, then you do pulses, then you stop, you give some time, then you do again, then you stop. It works.
Thank you.
Thank you, all the experts here, and thank you so much for all the audience joining here for the session, and I welcome the next session moderators to the stage. Thank you so much.
For this session is keynote lecture post-PCI management. The facilitator for this session is Sanjay Tyagi. The chairpersons for this session are S.N. Murthy, Devavata Roy, Shafiq Mathumad.
Everybody. So in this post-PCI management session, we have 3 speakers. So PCI beyond 1 year, that's...
Good afternoon, everyone. Thanks to the subject of DAPT, dual antiplatelet agent therapy. Beyond 1, it can be also used beyond 1 year in certain intelligence. And there comes the role of precision medicine, how to apply and how long you should go beyond 12 months. Carried out like Charisma, Prodigy, then ARCT, and most of them have showed that beyond 12 months there are certain benefits about the use of DAPT beyond 12 months, especially in the high-risk patients. And this has been demonstrated here. There are many trials, death is concerned. More or less, it gives benefit up to certain extent, but at the end of 12 non-cardiovascular deaths are concerned, there is time course of benefit versus risk of antithrombotic mechanism, plaque progression, prevention of systemic events, phenomenon by this. These are, I am talking about the conventional therapeutic approach. Then I'll go. This is a sort of summary slide to show how the antiplatelet regimen can be tailored. Ischemic risk, low bleeding risk, low ischemic risk, high bleeding risk, low ischemic risk, low bleeding risk, and all this can be characterized by different disease patterns that have been the different sides in the ischemic versus the bleeding risk, and ultimately you will see that on 12 months. But in high bleeding risk patient, you should not give, and that is the dictum. But what has been very interesting, beginning, they are having more chance of bleeding, and there is low ischemic risk, as has been shown here. And there are plausible causes which may cause the high risk of bleeding, and that is why the ethnicity-based or ethnicity-tailored antithrombotic therapy is also required. In case of PCI with atrial fibrillation where anticoagulation is given, and now you know that the newer kind of anticoagulant agents, DOAC or NOAC, they have platelet activities. So in this particular group, possibly one should not try with the triple antiplatelet agents or dual antiplatelet agents, but only one therapy, that is the NOAC or DOAC, can be continued beyond 12 months. In the market, the ACC-AHA guideline, which considered DAPT beyond 12 months in high-risk patient, ESC guideline also similarly gave the directions, and in only high ischemic risk patients it can be shown. And current ESC guidelines are also, and no significant of bleeding on DAPT, we may consider the therapy to be continued for beyond 12 months. But again, I would re-emphasize that too, R is human, and we should build a safer, healthy system. Primum non nocere, incorporated or added to the human intelligence, what we were talking about in my previous slides, then that is called augmented intelligence, which is to drive the field away from the conventional therapeutic approach to a specific group, machine learning, deep learning, and ultimately they are not just coming just like that in the computer. You'll have to go and give unique response to individual in health and disease in the next slide, that they can actually modify our treatment. So metabolomics and also the proteomics and all. And all these, if you combine all these together, form an interactome, which is based on the genome proteome, that convolutional neural network or CNN, they will form a subnetworks, and that will give rise to a new kind of phenotype, which will cause that clopidogrel is an agent which has got various response system. There can be more bleeding, less bleeding, like that. As I have said, from genotype to phenotype we are going, and ultimately the precision medicine is coming. Same thing I have talked over here, that omics-based AI for care of CAD is going to be the future. It's going to be the future for all kinds of medicine, including the dual and antiplatelet agent or CAD management and all this. And all this will be through the pharmaceutical based concepts. Always there is a myth versus facts. AI will replace the physician. That's the myth. But fact is, cardiology is a human enterprise. AI is much more transparent, but the fact is, AI is a black box. AI is very smart. The fact is excellent at narrow base, but at bigger base it's not. And AI will make all medicinal decisions in 10 years. Thank you very much for patient hearing.
Yes, Dr. Das, this is something that all of us will need to read a lot. But basically, we are all clinicians and we face problems in use of DAPT, antiplatelet therapy and all. Now, I would like you to just enumerate antiplatelet therapy beyond 12 months in cases where you use anticoagulant. You have to use anticoagulant therapy. What will be your message to everyone?
I think the answer is very straightforward. Whenever there is high risk of ischemia, there are so many subtopics like LM disease, complex diseases. In those cases, these patients are having high risk of, the ischemia. You are to prolong the antiplatelet agent therapy. They still got the benefit of using the DAPT for beyond up to 36 months.
In cases where you are bound to use anticoagulants,
having more chance of ischemia and low chance of bleeding, then in those cases, you should use single antiplatelet agent and much less with this combination. So in that case, you can go with the single antiplatelet agent.
Any questions? You can ask.
Call upon Professor Rothra, please.
This is a subset of patients
which is not very clearly defined, because if I search literature, because whatever this pathophysiology, heart failure post-PCI may be due to pre-existing LV dysfunction or due to ischemia and or mechanical chronic heart failure. And PCI is mostly done in patients presenting with acute coronary syndrome, different subset, post-myocardial infarction and chronic coronary syndrome. Patients undergoing primary PCI doing good revascularization going to heart failure later. Chronic subset. This is our own data from 2018 published in Indian Heart Journal that shows only 18.85% are in chronic stable angina. All others are unstable angina, cardiogenic shock, rescue PCI, post-MI and primary PCI. All these subsets can develop. 2021 our NIC data, highest from Maharashtra, that in 14.9%, next is Delhi and Karnataka almost 9.4%, and all others are shown here. So the incidence of heart failure among patients hospitalized for AMI varies among studies from 14 to 36%, because most of our data come from patients with AMI. GRACE registry, so 13% had heart failure on admission and heart failure in 2008. This is our data from Kerala acute heart failure registry. It showed almost 67% were having heart failure patients having coronary disease. So these are the risk factors. If the patient has atrial fibrillation, previous MI, old age, hypertension, goes to heart failure following PCI. This is predictor of heart failure post-PCI, one study which came 3,900 patients and included heart failure LVA more than equal to 50% without heart failure previously or at baseline. They found at a higher BNP level, lower eGFR and atrial fibrillation predict MI, predict heart failure, whereas male sex and long-term use of ACE inhibitor ARB show low risk of heart failure. So the mitigating factors, optimization of the medical management, patient with cardiogenic shock treated separately. If you look at this study, this trial, this pharmacologic therapy to prevent heart failure following that prevented progression of LV remodeling and thereby reducing the risk of heart failure. This again, if EF% EF, beta blocker and ACE inhibitors are class 2A and ESC it shows class 2B. So if you look at one ARNI, so it started with paradigm HF that it was given, and they showed the reduction of NT-proBNP compared to analyze further this Paradise MI. This failed to show statistically significant difference. The total fast and recurrent investigator reported report showed the sacubital valsartan is superior to ramipril even in acute heart failure in having clinical or preclinical disease or detectable cardiac in patients acute heart failure as well. So if you see, then ARNI and SGLT2 inhibitors are additive to each other. The two drug class add intolerability of the other. This MRA, there is 3 studies. The EFISA study is applicable in acute MI. The patients are included in 3 to 14 days if EF was less than equal to 40%. And it was found to be beneficial, reducing mortality and CV cardiovascular hospitalization. Here you see, besides our beta blocker, SGLT inhibitor, ARNI and MRA, the others like hydrogen nitrate and ivabradine and others have beneficial effect whenever indicated. So the time dependent starting of the drug, so immediate, if it is patients presenting with MI, immediate perfusion and revascularization is important, and within the 24 hours, ACE inhibitor, ARB or ARNI should be started. Beta blocker should be given 24 hours after, and aldosterone antagonist has been found to be beneficial 1 to 7 days after presentation. So these are development of heart failure in patients with acute coronary syndrome with a multivessel disease. The fast heart failure hospitalization or CBD is done. So complete revascularization is reduced. The risk of primary endpoint, fast hospitalization for heart failure and cardiovascular death, as well as fast heart failure hospitalization and cardiovascular death, overall death. When feasible, complete revascularization should be performed in all patients with acute coronary syndrome. Use of mechanical cardiac support has not been found to be beneficial. However, beneficial only with mechanical complications. These are the different ongoing trials going on, beta blockers, other agents. But as the patient with acute decompensated heart failure give diuretics, stabilize and start guideline-directed medical therapy. If there is mechanical has to be taken care of that, and after that, the guideline-directed medical therapy should be cutaneous coronary intervention, commonly performed patients with acute coronary syndrome, post-myocardial infarction. Most of the patients are patients with coronary multivessel disease presenting with myocardial infarction or post-PCI. Early initiation of 4 foundational drugs have shown beneficial in reducing the risk and developing a heart failure and mortality. Cardiogenic shock with mechanical complications is indicated. Aggressive risk factor modification. Thank you for your present hearing.
Thank you, Professor. In patient informational notice to the audience and among our colleagues also, 17, 3 for LAD, 3 for LAD RCA, and 2 for LAD and LCX. They are active. But of late they presented with a feeling of evidence of heart failure with rejection hypokinesia. The contribution of the small vessel disease among the patients of coronary artery disease in whom angioplasty and PCA was performed, the contribution of small vessel disease among patients with...
One thing I want to ask Rautre, do you use ARNI in cases of post-MI where do a PCI and they develop heart failure?
The sub-analysis following that, the investigator reported evidence of heart failure and class 1 indication in this case.
Ganguly to speak on intracoronary imaging, insights based on anti-lipid therapy. Professor Kazal Ganguly.
And friends, so at the onset, I would like to thank our convener of NIC. Here only, yes. Good. Now I can do it. So, spectroscopy, OCT, IVAS, virtual histology, MR angiography, and CT, coronary CT we have. So, vulnerable plaque, I won't go into the details. You know, it is endothelial lipid deposition, which shows the large lipid core, and followed, and above that there is a fibrous cap. And the vulnerability depends on the thinness of the cap and the amount of the necrotic plaque. Seeing the calcium, that is the vulnerable plaque, we take into account of total atheroma volume and then normalized to the length of corresponding to the median number of comparable slice in the whole population. So, percentage atheroma volume PAB represents the proportion of the vessel volume occupied by the atheroma is calculated as the percentage of PAB. By therapies is associated with 20% reduction in the odds of MACE. Models this showed. Percent atheroma volume, non-culprit lesion related to the plaque increase showed better benefit than the pravastatin. Certain trial, which is a comparison of atorvastatin with rosuvastatin, both showed similar risk reduction, but plaque volume reduction with rosuvastatin was greater than atorvastatin. Asteroid trial, rosuvastatin 40 mg was used, and there was significant decrease in the plaque volume. So, this is the yellow trial, 2 or 3 vessel coronary artery disease. After stenting the target vessel, non-target lesion underwent FFR, and that was defined significant when it's lesser than 0.8, and these patients are subjected to IVAS and near-infrared spectroscopy. As randomized into 2 groups, standard group continuous statin. The patient was taking dual antiplatelet therapy for 1 year, aggressive rosuvastatin 40 mg daily added to dual antiplatelet therapy for 1 year. Follow-up shows that the primary endpoint, change in the lipid core burden index at 4 mm maximal segment, was seen in patients who got the high aggressive therapy by 40 mg of rosuvastatin daily. Percentage change of lipid core burden index that shows that is with aggressive therapy, there is significantly better lipid core index regression compared to this conventional therapy. GLABOB trial is designed to assess the efficacy of PCSK9 inhibition on progression of atherosclerosis as measured by IVAS. So that showed again the statin therapy at the end, monotherapy plus statin plus monthly injection of twice injection of evolocumab, and that was studied by IVAS. Primary endpoint, percent atheroma volume significantly reduced, and total atheroma volume also significantly reduced when evolocumab was added to statin therapy. The LDL lowering and plaque regression, the amount of LDL lowering is directly related to the regression of the plaque volume. And again, the close relation between the achieved LDL-C level and median change of percentage atheroma volume in different studies, starting from GLABOB, asteroid, Saturn, IBIS-2 reversal, all shows as the plaque volume regresses, the chances of the MACE decreases significantly. The efficacy of PCSK9 inhibitor for plaque stabilization in non-culprit lesions of ACS patients by using near-infrared spectroscopy. There is a total lipid core burden index values are significantly and independently associated with the incidence of adverse cardiac outcome in patients with CAD with a continuous relationship. Retrospective study of 10 ACS patients and 11 culprit vessel lesions. Results showed that the lipid core burden index of the non-culprit lesions was significantly decreased after PCSK9 application. This study suggests plaque morphology can be altered by aggressive lipid lowering therapy by PCSK9. So fibrous cap thickness is defined as the minimum distance between the coronary artery lumen and the border of the lipid. And thin cap fibroatheroma is defined as plaque with lipid content in more than 2 quadrants, and the thinnest part of the fibrous cap is less than 65 micromillimeter. Significantly decreased with this evolocumab. Exploratory endpoint change in the that is the macrophage index. Again, that showed there is lesser number of macrophages in this group of patients, which is beneficial for this plaque stabilization. Effect of evolocumab therapy on coronary fibrous cap thickness. It was this OCT trial. It was done on patients who underwent dyslipidemia, LDL-C more than 100, and who underwent emergency percutaneous intervention. OCT measures that showed those patients who had evolocumab added to statin had fibrous cap thickness increased, and the lipid arc is also significantly decreased. This is the conclusion. Adding PCSK9 inhibitor evolocumab to statin therapy might produce incremental growth in fibrous cap thickness and regression of the lipid-rich plaque even after in the short term in the early phase of ACS. This is the pacemaker trial. Again, there is the multi-modality intracoronary imaging in patients with acute myocardial infarction, and that showed that the addition of alirocumab again significantly decreased the plaque volume and subsequently less incidence of this MACE. Compared to placebo, alirocumab resulted in greater decrease in percent atheroma volume by IVAS after 52 weeks of treatment. Alirocumab on the top of high intensity statin therapy resulted in a greater reduction in lipid burden and higher increase in the maximum fibrous cap. So these are the changes in the plaque volume and the fibrous cap thickness. Evolocumab stabilized the vulnerable coronary plaques and reduced their size. Evolocumab significantly increased the minimum CT density, reduced the remodeling index, and decreased the percentage stenosis of the coronary vessels. This is how this addition of PCSK9 helps in the ACS. It endothelial cell activation, inflammation is reduced, proteolytic apoptosis is decreased, lipid core and fibrous cap formation is decreased, thrombosis is decreased. Non-culprit lesion related recurrent MI was twice that of the culprit lesion over a long period of time. And this is the Swedish trial said real-world observational cohort study of more than 1 lakh patients, first time MI patients who underwent PCI were identified with the different culprit lesions, and that showed the early initiation of this evolocumab, that is the PCSK9, resulted in a significant decrease in the MACE in the subsequent period of time. So with this I conclude my deliberation saying that this addition of this PCSK9 with high intensity statin at this point of time. Even in inclisiran, there are coming trials also, it didn't include it, helps in the reduction of the plaque volume, increases the fibrous cap, and thereby decreases the mass and in the non-culprit artery, and that prevents recurrent MI in population. Thank you.
I have just one question, Professor Ganguly. Now, in a stented segment, do you do a lipid core burden index or a plaque volume index, something like that? And does
No.
it influence the restenosis rates?
No, it is mainly all these studies. They did this lipid core burden index in the non-culprit vessel. Yes, higher if it is. We have seen nowadays that's why the threshold of this LDL is lowered. We have seen lowered the LDL-C level. Chances of ISR is less.
No, if you do a plaque burden or a lipid core index in a stented segment, does it influence the restenosis?
Yes, we can predict it. We can predict it.
Okay, thank you, Professor Ganguly.
So if there are no questions from the audience, I think we can conclude this session. Thank you.
Thank you.
For this session is keynote lectures. The facilitator for this session is Rabindranath Chakraborty. The chairpersons for this session are V.K. Behel, Rajiv Garg, Jayant S. Varma, Ramesh Chakraborty, Vijay Prakash Pandey, and Anil Sinha.
So we're going to start the session straight away. I think the first presenter is Dr. Dhiman Kahali. He is going to talk to us on his late primary angioplasty. Are you sure it should be avoided? Dr. Kahali, please.
Respected chairpersons and August gathering. So we are going to talk about a very important subject, that's what is to be done in STEMI patients when they appear to us after 12 hours. So that's a very important and pertinent question, and all of us face it day on, every day. And if it is less than 12 hours, there is no dispute. We take to the cath lab, do the job. If there is no cath lab, we do fibrinolysis and try to do angiography between 2 to 24 hours according to ESC. And if the large area of myocardium is at risk, we go for bypass surgery. Problem and dispute is due to symptom onset more than 12 hours. If there is cardiogenic shock or heart failure, PCI is feasible, yes, primary PCI. If it's not, then cabbage in very rarely. Ongoing ischemia, heart failure, electrical instability, etc. are there, then of course we go for primary PCI, even it is after 12 hours. If the symptom onset within 12 to 24 hours, then of course we go for PCI. And this is the ACC recommendation, and update is also like that. Totally occluded infarct artery more than 24 hours and no symptoms or severe ischemia, it is class 3 indication. That means we should not touch it. Now, according to ACC 2017, in patients with time from symptom onset more than 12 hours, a primary PCI strategy is indicated in the presence of ongoing symptoms, hemodynamic instability, or life-threatening arrhythmias. A routine primary PCI strategy should be considered in patients presenting late after symptom onset. In asymptomatic patients, routine PCI of an occluded IRA more than 48 hours after onset of STEMI is not indicated. Now, in patients with STEMI who are treated with fibrinolytic therapy, as I told, angiography within 3 to 24 hours with intent to perform PCI is reasonable to improve clinical outcomes. In patients with STEMI who are stable and presenting 12 to 24 hours after symptoms onset, PCI is reasonable to improve clinical outcomes. That's a class 2A indication. Now, what about the ESC? I was present in the late-breaking trial session in Barcelona in 2017, and it was published in European Heart Journal in 2018. And many of you have got the booklets, beautiful one. And you see, it's flat. Up to 48 hours, they are recommending, even after 48 hours of acute MI, they are telling it is class 1A to 1C. But in the 1C, that is from 12 to 48 hours, if symptoms are there, hemodynamic instability is there, or arrhythmias are present, this is a class 1C indication. But see, everything is green up to 48 hours. And in the first 2 to 3 hours, if possible, fibrinolysis in the, if there is no cath lab facility, of course. And if primary PCI is to be done in asymptomatic stable patient, that becomes a class 2A indication with evidence B. And after 48 hours for the asymptomatic group, according to ESC, this is a class 3 indication, means we should not do it. So the patient comes with us with severe excruciating chest pain. And what are the figures in USA? Every year about 7.5 lakhs Americans have a heart attack. Of these, 5.25 are a first attack and 2,110,000 a second one. In 2010, approximately 1 in 6 people in US died of acute MI. Approximately every 34 seconds, one American has a coronary event, and approximately every 83 seconds, one American is going to die of a heart attack. The incidence of MI in India is 65 per 1,000 among 30 to 70 years aged patient. Now let us take a patient, 45 years male patient, had an acute anterior wall MI 3 days back, presently asymptomatic, akinetic LAD territory with preserved muscle mass, LV ejection fraction 40%, CAG proximal LAD total occlusion. Now, if there is no rest or severe inducible ischemia, it's in the red. No cardiogenic shock. Of course, if the patient has cardiogenic shock or serious arrhythmias, then of course we have to take the patient. If the patient has no significant left main disease or triple vessel disease, not a case of failed thrombolysis, and not a candidate for primary PCI. So these are all red. Now, this is one trial which is often quoted, and also we go by this trial data. It's OAT trial, 3 to 28 days after myocardial infarction, median is 10 days, total occlusion of the infarct-related artery, high risk for LVF less than 50%, proximal IRA occlusion, large at-risk region, 217 sites, 24 countries across the globe, PCI stenting plus OMT and medical treatment only in the other group with 1,100 patients. No significant difference was found in the primary endpoint, death from any cause, reinfarction, NYHA class 4 heart failure with hospitalization, admission to a short stay unit, and the values were insignificant. Now, 40% of patients present beyond 12 hours. This is the NCDR CAT PCI data of US. 896 US hospital, 29,000 outpatient, more than 24 hours after the MI have presented. Our country, it's much worse. Many patients come after 12 hours. No difference in adjusted monthly rate of PCI for total occlusion before publication of OAT. After publication, after 2007, ACC guidelines have revisioned and we have shown it. Now, these are the different mechanisms, protective mechanisms. We are not going to discuss about that. Persistently occluded IRA may be a marker and not a direct cause of increased mortality. Example, these different genotypes and increased lipoprotein A. Now, these are other trials, TAMI 6, TOMIS 2. You see there is no significant difference between the two procedures, conservative medical treatment and intervention. These are the other trials. You can find there is no significant difference, smaller trials. The criticism of the trials that the results of randomized trials are inconclusive and fail to show long-term benefits. This is regarding TAMI 6. Neither LV size nor LV function improved in the small trial published in 1998. These are all initial trials. In 1994, There was some improvement at 1 month, but no benefit translated to the mortality or morbidity. The other trial TOT, published in 2002, no difference in LVEF, regional wall motion at 6 months, death, MI, stroke, CCF, need for PCI more 1 year. This is from DCOPY data. And LVF improved at 6 months, but no difference in CV death, non-fatal MI or VT. This is also some meta-analysis data, individual and pool group differences in change in cardiac function and remodeling, nothing much to mention. This is one SUICI-2 trial, which has shown some positive results in 1,060 patients assessed by eligibility and underwent bicycle exercise test in these two groups. 450 excluded and 577 underwent stress imaging, 201 randomized only. One group randomized to receive percutaneous coronary intervention, the other group anti-ischemic drugs. But this was not very different, small trial, but you see the percutaneous coronary intervention in this small group of randomization behaved better than the drug therapy, but a very small trial to comment. Asymptomatics with patients with presence of unequivocally reversible perfusion, defects on new regional wall motion by stress marker perfusion, stress echo or stress radionuclide angiography, complete revascularization in 95% of the patient, and these patients, of course, were followed up long. Results were little in favor of the intervention group. Now, OD viability ancillary study. This was a smaller study. The extent of residual viability post-MI may be less significant in the contemporary era with aggressive post-MI medical therapy. Now, what are the criticisms of OD trial? They enrolled only low-risk population of patients at high risk, particularly those with low ejection fractions and proximal LAD occlusion, left main involvement, etc. They were not involved in OD trial. There was no serious ventricular arrhythmia in this group of patients. Though OD mainly enrolled patients who survived the first few days after MI and were clinically stable, they still have an annualized event rate of 4%, which is not very low. High-risk subgroups were not included, I told, who were identified prospectively in the trial still did not show any benefit. The most likely benefits of late opening of the IRA are in attenuation of LV remodeling. It would take a long time for the clinical benefit. In TOSCA-2, the companion angiographic sub-study of OD trial, there was an equivalent improvement of ejection fraction at 1 year. This means that the delayed reperfusion, there is very little chance of interfering with the remodeling. LV dilatations are already underway. If there is any attenuation of remodeling at all, the benefit may be counterbalanced by myocardial injury from procedure-related data. These are the other criticisms. This is the nuclear study of the OD trial. Sub-study showed no influence of baseline viability on LV remodeling at primary endpoint. These are the other, criticisms of the OD trials. It was severely criticized because of these reasons. For the present time and foreseeable future, stable patients, such as those enrolled in the OD with persistent occlusion of IRA late after MI and without severe ischemia, or uncontrollable ischemia, should be managed with an initial strategy of optimal medical management and not with PCI. These are some of the studies. And DOT to balloon time is very important. And these are the clinical outcome data. Test trial didn't show any benefit of aspiration, and all-cause mortality at 30 days was same. So this has been downgraded in the guidelines. This is the PRAMI data and examination with one particular stent. So this is one patient who came to us after 7 days, and the patient was symptomatic. You see the LAD is completely occluded, 100% occluded. So we normally go for direct stenting of these patients because we don't prefer balloon dilatation much before and after. And this is the artery with T3 flow, no low flow, no reflow, etc. The patient only you have to take some precautions in treating such patients, and we sometimes take these patients if the patient is symptomatic. So to summarize, ladies and gentlemen, after 12 hours of an acute infarct, this depends on the clinical scenario. If the patient is symptomatic, of course we take it, but the European Society, the American College, both have recommended that if the patient is symptomatic, if the patient has heart failure, if the patient has some arrhythmias, we can take the patient up to 48 hours. The European Society is more liberal. They have given after 48 hours also, if the patient is symptomatic, we can take the patient, and after 12 hours or any time after the MI, if the patient is in cardiogenic shock, we can take the patient any time after the MI. And the prognosis is not bad, and that because there is always viable muscle like in proximal LAD, and the OAT trial did not consider, according to the trial which is most often referred to, did not include patients when the patients were severely symptomatic, or the patients were in cardiogenic shock, or with proximal LAD occlusion, or with left main occlusion. So what we have been practicing, we'll continue with that, and both are, I think, guideline recommended. Thank you very much for your kind attention.
Thank you, Dr. Kahali. It's a wonderful presentation. I think being a keynote lecture, we are not supposed to ask any question.
Thank you,
So
Robin.
thank you.
Thank you very much.
May I request Dr. Ashok Sheth to educate us on a very, very interesting topic. That topic is TAVR with coronary perforation. Dr. Ashok Sheth.
So good afternoon, friends, chairpersons, colleagues. I'm going to talk about TAVR with coronary protection. So as we grow to younger and younger patients, in terms of low risk, clearly there's an increasing importance for coronary access in the lifetime management of our patients. And not just for coronary access, we must understand that while coronary occlusion during TAVI is a rare complication occurring in less than 1%, is the most devastating complication with invariable death if preemptive measures are not taken. Those who actually have coronary occlusion, and usually it's the left main because the left main sits lower than the right coronary artery, you can't then take measures. Those who are not protected are the ones who invariably die, and even those who are protected have a high mortality. So we must understand that coronary occlusion following TAVI is truly devastating. Valve-in-valve is the highest risk subgroup, and therefore preempting procedural planning, and therefore avoiding this complication is the mainstay of a safe and successful TAVI procedure. Today we're going to talk about the risk factors for coronary occlusion in native TAVI as well as valve-in-valve TAVI. We're going to discuss the strategies for prevention of coronary occlusion in native valve TAVI. We're going to understand the strategies for coronary protection and prediction in valve-in-valve TAVI, the bailout strategies that we can deploy, and of course discuss coronary access following TAVI, which is has important implications in the lifetime management of patients, as also has implications for all interventional cardiologists, because these patients may land up at any center in the future with acute coronary syndrome needing urgent coronary angiogram and perhaps coronary intervention. If the risk factors and the prediction of coronary artery occlusion during TAVI is an interaction of the valve leaflets with its surrounding structures. Of course, coronary height, less than 10 millimeters, is a risk factor for coronary occlusion. The sinus width, understandably, is another risk factor for coronary occlusion, and to less than 28 millimeters. But it also relates to the annulus size and the valve size which is being put, because there has to be any valve which goes in will push the leaflets on the side, and understandably,
if the sinuses are small, the leaflet would actually be totally sequestrated there. The combination of low coronary heights and small sinuses is the worst predictor of coronary occlusion. Then, of course, there's the calcium on the leaflet, where it is. If it sits, huge chunky calcium bulk sits here, as the leaflet opens, it would open right in front of the ostia, which is understandable. Thickness of the valve leaflets is an important predictor. The length of the leaflet compared to the height of the, if it's higher than the coronary ostia height, again, that would close off the coronary. And finally, we actually understand the height of the sinotubular junction, primarily because the valve which fits in has internal, external skirts, and therefore has its own commissures. And if this is short, then again the valve would close off the coronaries on either side. So it's a clear understanding, and that's what we understand when we review the CT angiograms. Like I said, shallow sinuses, high coronary ostia heights are all those are great. This is where we come to wide sinuses of Valsalva, but low coronary ostia height, interaction. This is the interaction which is happening. You've got shallow sinuses, but higher coronary. The moment you have shallow sinuses and low coronary, these leaflets are just going to close off, and those are the worst predictors. While we've discussed immediate on-table coronary obstruction, and we know that that happens as we've explained. We've also explained the valve, and we'll just come to that further on. But there's also late obstruction of coronaries, and this has to be also well understood. It may happen over the week. It is usually related to sequestration, thrombus formation in the new sinuses that form. And you'll understand this by this figure, that as the valve sits here, the new valve sits here, between the valve leaflets and its frame is going to be the newer sinuses. And of course, between the native leaflet and the wall of the aorta is going to be another. And that are dead spaces where thrombus may form. And therefore, for smaller valves, for smaller anatomy, we actually, in the first 3 months, do put them many a times on anticoagulation rather than just antiplatelet therapy, though that is still arbitrary and not proven. But thrombus does form, and thrombotic occlusion of coronary arteries over the next week is a reality. We need to understand the strategic prevention, therefore, the steps we can take in the native coronary. Of course, we will just come to the valve itself, the strategies. The choice of valve is important. Balloon expandable have a higher chances of closure of the coronary than self-expandable, and that's understandable just because it's circular and it pushes out due to balloon expansion. Leaflets get pushed firmly and viciously against the coronaries. Chunk of calcium may be pushed into the coronaries, and therefore this is an important aspect to remember. The valves which are self-expanding, of course, if they are shorter frame, if they are larger cells and have shorter frames, then of course they are less likely to occlude coronaries, or access to coronary or coronary strategies to prevent coronary occlusion are easier than valves which have smaller smaller cells. There are valve choices which can be designed. This is like a accurate neo, has these crowns which actually compress the leaflets, and in this case, even up to less than up to 8 millimeter coronary height can actually be treated with accurate neo valves. We tend to, in the situations where there's higher chance of coronary occlusion, or we've got low coronary heights, less than 10 millimeters, we tend to implant valves lower. But whenever in doubt, believe you me, learn to protect coronaries. It's an important aspect of TAVI, and there is optimal ways to protect coronaries should be well understood. So coronary protection is important. For example, how do we protect coronaries? Do it properly. Do it completely. What that means is here. That actually means that this is a patient who's got low coronary heights. It's not just keeping a guide catheter into the coronary while we are doing the TAVI. It actually also means keeping a wire down and keeping a stent into the coronary, because pushing a stent through a stent frame when acute occlusion happens is fraught with complications and death, and again, that's been well proven. Wire protection does not save lives. it has to be the complete device inside, which means stent into the coronaries, so that if the coronary was to occlude or there was threatened closure, you could just bring back the stent and implant it into the left main ostia. However, it has to be a guiding catheter. It has to be a guide extension catheter and not a guide catheter. And that is well understood by the next diagrams that you will see, that here is a guide extension sitting, a stent, and here is a wire. The guiding catheter is here. This is a guide extension. When a pre-dilatation is done, you see how the guide extension gets pushed into the left main. Well, if this was a guiding catheter, it would dissect the left main. As you see the valve coming down, see how again the interaction occurs between the guide extension catheter and the valve, so that the guide extension just deep throats viciously. Here it goes, viciously into the LAD. If this was a guiding catheter, it would just dissect it. Guide extension catheter also allows a track for the stent to be brought back if it was not needed to be deployed. Here again, the guide extension catheter is, sorry, why did that? Okay, let's go on to the next. It gets totally deep in, and when it gets totally deep in, you can actually see that it can be brought back because it's softer. And finally, you can see the valve being implanted. It's implanted in a lowish position. We normally implant valves higher. This is at 70-30. We now sometimes do it at 90-10 to avoid need for pacemakers or conduction defects. But here it is implanted, and we can actually, we see that we're well away from the coronary. We've implanted it low. We now are able to have the steps of retraction, and I want to show you the steps of retraction. Again, this has to be well understood. When we retract, this one probably tells you better. This is a valve-in-valve case, a small valve which has degenerated in 5th year after surgery, severely stenosed with a high pressure gradient. Epic supra, 19 millimeters, an extremely small valve. Here we actually measure what we call the VTC. Yeah, you can see that. VTC, where that's the virtual ring to the coronary distance. Anything between 3 and 6 has a moderate risk of occlusion. More than 6 millimeter has a low risk of occlusion, and less than 3 millimeter has a high risk of occlusion. And here we see that the coronary is just 3.3 millimeters. Also, the coronaries are situated at a low height, which is 5.2 millimeters on the right side and 9.6 millimeters. This case, with a small annulus in a lady, has an extremely high chance of occlusion. Well, this has been implanted deep. The valve is FX, self-expandable. You can just see the epic valve ring right here, as faintly as that. The valve has been implanted accurately and deep. Protection has been done, wire, stent, and guide extension catheter. But now, after watching for 10 minutes, and we must watch for a duration of time that the coronary is not occluding, we first bring the stent out, but leave the guide extension there, because sometimes even the wire can uphold the leaflets. After watching it for another couple of minutes, you will see that the wire is brought back and the guide extension is still left in the left main. We watch this and then bring the guide extension back and still sit in the sinus and watch the ostia of the left main. And now that we are quite sure that we're not scaffolding any leaflet which could fall once we've withdrawn the guide extension catheter, we bring the guide extension catheter back from behind the frame to into the frame and away from the sinus. And of course, the coronaries are flowing. So I think it is very important to understand how to protect and the steps to decide that the coronary is not going to be occluded and to move ahead. The only reason I would put a balloon expandable valve in such small annulus is when I think that there are no sinuses and the coronary heights are low, because balloon expandable valve will allow me to get into the coronaries much easier than a self-expandable valve, as is in this case. No sinuses practically. This is an effaced aorta with practically no sinuses. Coronary ostia height on the left side is 9.4, which is less than 10. So I'm very wary in this patient that this will result in coronary occlusion. Furthermore, there's severe calcification on the non-coronary cusp side, which will therefore push the valve towards the left coronary cusp, and that makes me extremely worried. Such patients are the only patients who we do in general anesthesia. 99% of our patients are done on conscious sedation. This we put on general anesthesia. This is high risk for coronary occlusion. Must remember, if a patient is invariable coronary occlusion, he should be considered for surgical aortic valve replacement, and only if surgical aortic valve replacement is considered high risk do we transfer on to protected, extremely protected TAVI to prevent coronary occlusion. So this is a chunk of calcium in the non-coronary cusp, which will push the valve to the left side, and we choose a self-balloon expandable valve. We do the coronary protection as I've outlined. We pre-dilate with a smaller balloon. We have a deeper implant of the valve. We check the left main for 10 minutes after deployment, and you see all those. But you will also see that there was a residual gradient because of a small balloon expandable valve. The supraannular self-expandable give us better gradients and less patient prosthesis mismatch. However, we post-dilate it. We get the gradients down to less than 20, and here we are still lower. The valve frame is lower. We still have access, as you can see, into the coronary. We can go through this top frame into the coronary at any time. And when you see this, we have our left main just above the coronary ostia, above the frame or at the frame. But you see, there are no sinuses. It's been sequestrated completely. You can see the valve just sitting right here next to the coronary, and there is no sinus at all. These are really risky cases, but they do well. The bailout strategies, of course, are that you can have a situation of a coronary occlusion at any time. Here's a right coronary artery, which everything went fine, which wasn't low. We implanted a valve. You can see the distance after the valve implantation, the right is flowing. But 5 minutes later, you can see the ST elevation, VT, hypotension, and the right coronary is gone. That's because a chunk of calcium went into that coronary. Of course, bailout is not easy. These are flush occlusions behind the frame. One has to go past the wire, perhaps put a guide extension catheter in, and then put a long stent in, which we call chimney stenting, which the stent comes out from before the frame. One can actually therefore see this on IVUS, optimize the stent, and then bail the patient out with a long chimney stent. And the chimney stents aren't ideal, but are life-saving procedures as a bailout. I will soon finish my talk. It's been seen that as long as you protected the coronaries, the biggest risk factor is absence of coronary protection, associated with higher prediction of 30-day death, myocardial infarction, cardiogenic shock. But if you have protected the coronaries, you're able to bail out rapidly with the chimney stenting. Patients do survive and live. So protect coronaries well and properly. With that, I think I'm going to finish my talk, even though it could go on, but it's important to finish in time. Thank you very much for your attention.
Thank you very much, Dr. Seth. I think as a keynote lecture, we don't have
Thank
opportunity
you.
for questions, but
Thank you very much.
Fantastic talk. Thank you. Yes. The next speaker is from our good friend from Nepal, Chandramani Adhikari, on ASD device closure and Nepal experience.
Thank you, CSI, for giving me this opportunity and share our experience on ASD device closure. So we all know the history of ASD device closure, that it was started in 1975, and in India it was done in 1992. And we all know that Emplazer is the preferred or most commonly used device, and it was approved only in 2001. So ASD device closure in Nepal was started in Saidganj National Heart Center, the center where I work, and it was in 24th February 2007. So this is the institute. It was established in 1995. It's 300-bed hospital, government funded, 4 catheterization laboratory. We do 24/7 primary PCI. We have done more than 61,000 CAG so far, more than 22,000 PCI, more than 200 ASD device closure, more than 1,000 PDA device closure, more than 100 VSD device closure, more than 9,000 PTMC, and we have started TAVR program in 2020-22, and so far done 24 TAVR in our center. ASD device closure is being done in other centers also, but they are doing in less number. So they are, only 2 such published cases from other center in Nepal. But other center in Nepal, they do cases, but not in big number, less than 5 cases in the private hospital like Norvik, Noble Medical College, BPKHS, CMC, and HAMS. And some of the new centers are coming, they are interested to do AST device closure in those centers. So most of the device closure is done in my center. So this is our data. So we started in 2007. So 2007 to 2015, we have done less than 30 cases. And from 2016, we started doing in big number. In 2020-23, we have done the maximum number of AST device closure, that is 338. And till June 2024, we have done 187 cases. So I think this year we'll beat that mark. So there are 2 phases. From 2017 to 2015, in 9 years, only 174 cases were done. All of the cases were done with the help of the proctor. It's under general anesthesia, under transesophageal echocardiography guidance. From 2016 to 2023, in 8 years' time, we have done 1,724 cases, most under local anesthesia and most under transthoracic echocardiography guidance. So in 2016, we started with a proctor help, but from 2017 onwards, we are doing independently. So in the initial stage, most of our devices were Emplazer, followed by LifeTech, and in later half, we still prefer Emplazer, but we use Lepu, Occlutech, LifeTech, and Emplazer PF4 device. So what was the game-changing mood in 2016? So introduction of the device closure under local anesthesia and transthoracic guidance was the game changer. So in 2016, we did 3 workshops, 1-day workshop. And in the first time, we did 10 cases. In July, we did 44 cases. These 44 cases were done within 24 hours. So that was the number. So the person who helped to develop was Dr. Shiva Kumar from Madras Medical Mission. He came for our first 2 workshop in 2016. After that, we did good number of cases, and we have published our experience in national as well as international journals. So our success rate at that time in 2016 to 2018 was 94.4%. And in hospital complication, though we have a complication of pericardial effusion, device embolization, even death during the device closure procedure, but this is what we want to say, that we still have some complication, but that complication are going to be minimized we get much more experience. We have experience of doing with a bigger device. So during from 2016 to 2019, we have done 27 cases of AST device closure, in which we used more than 40 mm devices, and we followed up them, and only we could not follow 1 case. So in most of the cases, in only 1 case, that it still have dilated RA and RB, mean transcritic TR pressure gradient decreased from 44, mean of 44 to 18, and we can say that transcatheter closure of AST device closure with bigger device is safe and effective in short-term follow-up. We have done in elderly also. So from February 2016 to July 2018, we have done 48 cases of AST device closure in elderly, that is more than 50 years. And what we conclude is AST device closure can result in improvement in clinical and hemodynamic in elderly adults. So maximum age of the patient was 72 years. He was asymptomatic before and came with the symptoms, so we closed that device, and he has got the symptomatic benefit. Not only that, in guidelines there is no clear-cut evidence or clear-cut recommendation that whether we should use the single antiplatelets or the dual antiplatelets therapy after the device closure. So we did a small observational study in 140 cases, and our results suggest that the single antiplatelets therapy with ASA is as safe and effective as aspirin plus clopidogrel after AST device closure. So we have done a lot of poster presentation. One poster presentation was done in CSI Frankfurt, that is transcatheter echocardiography guided atrial septal defect closure in children. And it's about LV diastole dysfunction in patient with ST secondum, impact of transcatheter AST closure on right atrial and ventricular dimension and function in adults. And we have presented some of the interesting cases of AST device closure in Himalayan country Nepal in CSF Frankfurt 2022. I'll be presenting some of our cases in the later half of my presentation. Not only that, we have presented in national and as well as international conferences. So when all rims are of AST are present, the device closure procedure is quite easy. But the thing is, we don't get such simple ASTs. In our audit, which was published in 2017, only 4.1% of the cases had all rims and that are good. In many of the cases, they are floppy. So though easy ASTs are only 4.1%. And also we did one more study, so it's the prospective study. In this study, all rims were present and good only in 6.3% of the cases. So most of our AST, either they will be having absent rims or the rims will be floppy. So I'll be sharing some of the interesting cases which we have done from 2016 to 2023. So this is the case. This is the case in an AST device closure in post-CABG patient. Somehow the AST was missed before the CABG. So patient came to us with the diagnosis of AST. So we don't want to subject him for the second surgery. So we did AST device closure. This was the case we did with TE under local anesthesia. And also AST device closure after primary PCI. Patient presented with acute atrial basin MI. I think you can see those stents over there. But this case was managed in some other hospital, not in our hospital for acute MI. She was, that patient was underwent primary PCI, and after primary PCI, she was found to have AST, so referred to us for AST device closure, so we did the AST device closure. And during one of the workshop, the AST device got immobilized. It was in RPA. So what we did is we snared the device. There was a lot of discussion whether to send that case for surgery for the repair. But what we thought is, no, we are not going to do that. So what we did is we did AST device closure in the same setting with a balloon-assisted technique. This is how we did. And AST device closure in dextrocardia with situs inversus totalis is a very rare entity. So it was diagnosed by some of the cardiologists in the other hospital, and he was referred to us for device closure. And then we did TE. We found out that the rims are suitable for device closure, and then we did it with the ASO22 device. This was one case. After this case, we again get one more case of same case. 19-year-old unmarried girl referred for AST device closure after diagnosis of AST and dextrocardia. This is with all the images. Even we did CT to confirm whether it is associated with any other disease or not. And then we did AST device closure in a dextrocardia case. This is the second case. So this is the X-ray at 3 months follow-up. Luckily, just last Wednesday, she came for follow-up, so I kept these images. You can see the dextrocardia. This is the second case we have done so far. And we know that we can close AST, multiple AST with single device or two device. The main difference is if the two AST are separated by 7 mm, then it's better to do it with a two device. But if it is, if those AST are separated with less than 7 mm, we can do it with the single device. So this is a case with the two AST are separated by 7 mm, so we did with two AST devices. This is the first case we have done in our center with two devices. And in this case, we did with a single device because the two AST were separated by a very thin rim. So we even did the TE to confirm that. We balloon size it. Then with the help of a single device, we closed it. A combined AST device closure and a BPB, we all know that if AST is associated with some other lesion, then it's ideal go for surgery. But this was an unmarried girl, so she was referred with AST and PS. So what we thought, as she's unmarried, why don't we do a BPB on her and do a device closure? We did TE first and confirmed that the AST can be done with the transcatheter way. So what we did is we first did a BPB, but in this case what we did is we did BP with the not with the Tay-Sachs balloon, but we did with the PTMC balloon. It's so easy to do it. So we saw the gradient, it reduced from 54 to 31. So after 1 month, we again called that case for AST device closure, and we successfully did AST device closure. Again, after this is at 1 year follow-up, after device closure, the mean gradient was 15, peak gradient was 15. And also after this case, we again get one more case, so we recorded everything. This is how we did. And the gradient from 58 came down to 15, and we did the device closure. AST device closure with PCI, we did in the patient with primary PCI, but this is a case when we did PCI first and then we did a device closure. So again, one more case, she was diagnosed with AST and coronary artery disease, so she was referred to us for AST device closure and PCI, so we did it in the same setting with growing experience. So you can see here, we first did the AST device closure, device was there itself, and then we did the PCI of the LCX lesion, and then we removed the guiding catheter and deployed the device. And AST device closure in the national football player, we started a program of screening of all our national football player, even cricket player were screened, and the football player got screened. And one of the lady was found to have AST, so she underwent AST device closure, and she returned to international duty and was runner-up in South Asian women's football game. AST device closure in Sherpa, I think no one can do this type of cases. So this Sherpa was 57 years old male, climbed Mount Everest for 17 times and diagnosed have AF and AST and referred to us for AST device closure, but he was planning to go for AST device closure within a month. So this was the images. This AST is simple to do AST device closure, but the thing is he needs to go to climb Everest within a month. So we closed the device and he went to the base camp of the Mount Everest. It's around 5,364 meters above the sea level. He was helping a foreigner to climb the Mount Everest, but he came back as foreigner could not go above the base camp, but he was able to go. After a few months, he went to the expedition to climb Mount Everest, and he successfully climbed Mount Everest. So this is the images after he came back climbing the mountain for the 18 times. This is the image. And this is the case we recently came for follow-up, and it's interesting because he presented to ER because of palpitation and was treated for arterial flutter and found to have dilated RA and RV. We did T, found to have AST. And he completed AST device closure. Now his ECG is sinus rhythm, though we cannot ask a question. But I have a question in this case. Patient is in sinus rhythm. Now, what shall I do? Because he was presented with arterial flutter previously. Should I start on anticoagulants or any other things? That's a question to the expert over here. Yeah. And with the help of experience on AST device closure, we have started a PFO device closure in our center. But we want to do more, just like Pepsi. And we want to start a transcatheter closure of sinus venous AST with the help of expert from our neighboring country, India. And thank you all who helped us to develop this field. Dr. Radhakrishna, who was there, who used to come for AST device closure before 2015, and Dr. Bharat Dalvi, Shiva Kumar, Jay Raghunathan, Dr. Neeraj Avasthi, Ravi Ranjan Tripathi, Edwin Francis, and Biswajit Pandupai, they were very helpful to do workshop during our initial phase. Thank you very much.
Thank you very much. Good talk. Being a keynote lecture, there is no question.
Thank you.
Okay.
Thank you.
Thank you. We close the session here, and I think there's a lunch break or some industry sponsor session.
Hello, check. Good afternoon, doctors, ladies and gentlemen. My name is George Anthony, and I'm responsible for marketing for the devices business of Involution Healthcare. I would like to extend a very warm welcome to everyone who is gathered here today for our lunch symposium titled Unblock with Confidence. This session, before I get into the details on the session, I just wanted to take this opportunity to thank the scientific committee and the organizing committee of NIC Chennai for giving Involution the opportunity to be part of this keystone event. Thank you, sirs. Our lunch symposium this afternoon, Unblock with Confidence, is divided into two parts. The first part will have a session titled Premier Elite Sharp, the AI-powered cath lab transforming cardiac care, delivered by Dr. Colonel Anil Dull. This session will be followed by a short session on the status and interim analysis report of our very own Alchemy study, which will be presented by Professor Dr. Upendra Kaul, and finally a complex case in interventional cardiology that will be presented by Dr. Hitender Bhagwatkar. I would like to thank all our speakers for accepting our invitation and agreeing to be part of this Involution Lunch Symposium today. Thank you very much, sir. So without further delay, I would like to invite on stage Dr. Colonel Anil Dull for his session on Premier Elite Sharp, the AI-powered cath lab transforming cardiac care. Over to you, sir.
If it's a challenge to have people in regular halls, then at lunchtime, I guess hunger pangs also drive people to lunch halls rather than be here. All the same, I've been tasked by this very energetic bunch of people to speak on an indigenous cath lab, which is doing us really, really proud, because what started was not really an effort to build a Maruti 800, but to ultimately build a Porsche of cath labs. So in this, I'm sure that many people have experienced the transition from what was Premier Elite to a Premier, and this had a 3MHU grid-controlled LMB tube with a 100 kilowatt high-frequency generator, 120 degrees gantry movement, plus minus, and a dose-saving feature which is specific, with a 43-inch medical-grade monitor with deeper angulations. And there were some optional features like a virtual FFR, a real-time stent clarity, and IVUS or OCT co-registration. This kind of matched most of the high-end international cath lab brands which are available anywhere in the world. And we're proud to say that the installations which have happened with these cath labs are doing phenomenally good work. To increase the penetration of catheterization services, we need to have more and more cath labs. So in which case, more and more patients will benefit from early therapies, especially life-saving therapies. And in over 22 states, 218 cities, about 450 odd cath labs have been sold with about 1,400 partner hospitals. It makes us all very, very proud and happy to say that this is a good thing happening, and India is getting its due with world-class cath labs available at value segment costs, which can provide immediate attention to patients and not deprive them by having to wait or travel long distances. Today, what we are going to talk about is some new features which are going to be introduced, which have been introduced in a model called the Elite Sharp, which include an artificial intelligence-based instantaneous QCA, and an indigenously developed technology, an in-house developed technology for an artificially intelligence-based magnification, which can really be of great assistance to the operator. So we all know that cardiovascular therapeutics and diagnostics are very, very important. And the point I was trying to make is that even people living in remote areas do have the same statistics of myocardial infarctions and deaths, which can be prevented if we actually provide services. We are dealing with some kind of physician shortage. About 18% cardiologists are needed. More than 18% increase in the cardiovascular physician pool is required every year. I was at an NMC meeting a few weeks ago, and I was informed that 700 cardiovascular physicians will now be graduating every year from the various DM and DNB courses across the country. So we need to really know how well we need not just people, we also need cath labs. So we also know that the accuracy of visual estimation, a two-dimensional topography, is kind of limited, sometimes does not give you a functional assay, does not estimate calcium, does not estimate physiological severity. So here is a patient, I think, that has been selected. And if anybody would like to read this angiogram, we'll obviously find that there is a circumflex artery with at least 3 major obtuse marginals with significant disease. And if this was to be subjected to a visual estimation, we could identify the lesions and plan an intervention. However, if we were to have tools like this, which do not take any time to be developed, can give us an idea not only about the lesion length and the diameter, which are reasonable, may not be perfect, they are more QCA based, they are not truly based out of doing an intravascular imaging, but we get also an idea of a virtual stenting that has been done, a virtual treatment that has been delivered to this patient. So this estimated the lesion length, the diameter stenosis, and the proximal and distal diameter, so that you can choose your stent appropriately. And this can really, with this solution, you can, in a 2-second interval, you can, with state-of-the-art accuracy, where in a time-effective workflow, it can actually do an immediate, and this is all using artificial intelligence. So a lot of images have been taken previously. It leads to automated vessel segmentation, a lesion analysis, and then a recommendation. I found this very funny. It helps you identify the vessel, which I think cardiologists by themselves are reasonably okay to identify the vessel. But it is a useful tool for not just pre-PCI, but also for a post-PCI analysis. And this is something, if you see it in real time, this is an angiographic image acquisition. And once you start the process and the frame recommendation happens, the frame identification happens, and quickly, in 2 seconds, this does a vessel segmentation, and this will give you an accuracy of 0.99 and an F1 score of 0.91. And this quickly gives us, allows us to use this to plan a virtual PCI and decide as to what we're going to do. So here, a 41 millimeter lesion length, you know exactly the size, and the results come out absolutely crystal clear in front of you. We all know that we have to match the size of the stent with the distal vessel. So in 2 seconds from the angiography, you have a F1 score segmentation of 91.91 and an accuracy classification of 0.99. So it really is a value proposition for physicians in terms of decision-making, streamlining workflow, in terms of hospitals, for resource utilization, increasing number of patients, and also the government, if we were to look at optimizing health costs and innovation, and the patients, because there would be better prognosis, less risk, and reduced costs. Similarly, there's an in-house developed artificial intelligence technology which does an artificial intelligence guided advanced magnification, superior resolution with noise reduction, which has basically an intelligent zoom without any increase in radiation exposure. And you just say, select this. So now we know that we would like to get a mag image, especially to look at the obtuse marginal, but getting a 3 mag without deteriorating image quality, without extra contrast injection or C-arm or table movement can be very useful in identifying these lesions. And this can be incorporated in the workflow. You have a cropped ROI, you have a magnification, you have a magnified output, so that we can actually proceed to treat this patient in a better manner. There are many clinical benefits. There is no IQ deterioration. It can look at calcium a little better, dissections, perforations, even air embolism, osteal disease, thrombus, bifurcation or trifurcation lesions. And here is a patient in whom this has been amply demonstrated. There was a suspicion of air embolism, which on magnification is unfortunately and embarrassingly proved. And here is an osteal stenosis, which we knew that this was an osteal circumflex disease, but we can see not just circumflex, we can see the LED ostium a little better. And if you're looking at trifurcation situation where the ramus is hidden, as in the last case, which is coming from Maldives, which Dr. Shiban was doing, you can look at the trifurcation here in better detail with an automag. You can also do a bifurcation lesion, and you can see the calcium here, and it can all be enhanced by using this AI, artificial intelligence magnification system. You can look at a distal RCA bifurcation, and again, get a better idea that this is a normal bifurcation. The virtual FFR is a less invasive angio-derived mathematical modeling. Instruction from 2D angiogram is created fully automatically. It is also supported by clinical studies like FAST1, FAST2, FAST3. It's an FDA-approved kind, and you would be able to precisely determine how you would like to treat this patient. So these benefits are that only 2 angiograms are needed. There's no pressure wire. It's no hyperemic agent, 1-minute analysis, and it is actually CE-marked, F10K cleared, and it has a high linear correlation to invasively measured FFR at high diagnostic accuracy and a very low inter-observer variability. If you can, what about co-registration with IVUS OCT? They have in-house technology which is IV Link, which can actually help co-register, and by using just 2 angiograms, one with contrast and one without, with any IVUS, any proprietary IVUS or OCT system, it can actually be used to create image merge, and this is something which can co-register, and it is FDA cleared and CE marked, and it is vendor independent, and with an automatic co-registration, it helps the operator do more. There are many other things that we are looking at. We have suggested to them a few improvements. You might be able to do away with technicians. You might be able to have, even for structural heart intervention, something like an echo navigator is likely to be made available. The footprint of involution is increasing the world over, and we're proud to say that this is a very well awarded and rewarded company. They wanted to give me details, but I thought it's a little embarrassing for anybody to say that they are so well awarded and rewarded. But yes, they did get the Red Dot Design Award and a Good Design Award in 2018 and 19. There are many R&D initiatives which are happening, Clearview technology, the in-house development of a combined OCT IVUS system, some post-processing image resolution, even a cardiac CT, rotational angiography is being developed. There are at least 6 patents on IPR, some new devices like drug-eluting balloons. We discussed a few days ago in the fellows course that there might be a covered a drug-coated covered stent which will be made available. There are some micro-hole drug delivery, microneedle drug delivery, vessel closure systems, an IVL-like technology, and also moving into the structural and heart failure sphere with many new innovations, including robotics. So therefore, this is an exciting place, an exciting company, and it's my privilege to give you all this insight. Thank you very much.
Thank you, sir, for that cool presentation on Premier Elite Sharp and also taking us through some of the key features and benefits of what the Premier Elite Sharp can deliver. As I mentioned in the beginning, the second half of this lunch symposium, Unblocked with Confidence, is focused on our alchemy study and some of the interim results and the analysis of the same, which will be, as I mentioned in the beginning, presented by our very own Dr. Professor Upendra Kaul, who will now take us through this presentation over the next 15 minutes. So without much delay, sir, I'd like to invite you on the stage.
Good afternoon, friends. It's my pleasure to be associated with Involution, a company which has plenty of solutions from cath lab to stents now and so many other things in future which Anil just enumerated. So every solution for an interventional cardiology should be coming from this company. And I'm going to talk about the stent, the Eternia stent, which is a low strut thickness stent of 60 millimicrons, and it has got a very good design, very good crossability, and polymer is biodegradable polymer, as you see in most of the present-day stents. The study which we embarked upon is Alchemy study, which is basically an acronym of about a real-world all-comers study using Eternia stent. Now, the study design is divided in two parts. One is the observational multi-center study in which we plan to 1,000 cases, out of which 500 have already been done. And in that arm, there will be a clinical follow-up at 1 month, 6 months, and 1 year. And then there is an ambitious sub-study in which QCA will be done in 200 patients. And out of those 200 patients, 50 will also have a optical OCT evaluation to see the new intimal hyperplasia and the thickness and other things. And then clinical follow-up at 9 months. The endpoints of the study, the primary endpoint of this study is the DOSE, that is the device-oriented composite endpoint at 1 year, composite of cardiac death, target vessel MI, or clinically indicated TLR. Secondary is, beside DOSE, the patient-oriented composite endpoint of all-cause death, any myocardial infarction, any revascularization, major adverse cardiac events, target vessel failure, non-target vessel-related myocardial infarction, and then stent thrombosis, both definite and probable, and also looking at severe bark bleeding. QCA and OCT, as we already discussed, as a part of a sub-study, which will study, the QCA will study the late lumen loss at 9 months, percentage diameter stenosis, angiographic binary restenosis, in-stent and in-segment minimal lumen diameter. And the endpoints for OCT will be the proportion of in-stent and in-segment binary restenosis and the proportion of stents uncovered and malapposed, area of restenosis and new intimal hyperplasia thickness. So all that should give a lot of information not only about the clinical endpoints, but also about the angiographic and intravascular imaging endpoints. The total patients, as I told you, 500 have been enrolled. 50% of the patients have already been enrolled. The study has started recently, and so we don't have a very long-term follow-up of it. We have, 1 month follow-up of about 88.4% of 398 patients who have completed 1 month. And visits completed till 6 months have been out of 40, 28, 70%. And the SAEs, which are still being adjudicated, recorded till date is 1.2%. One of them obviously was because of cor pulmonale, but others which are cardiac are still being, in the process of adjudication. And these are the centers we have, for the main registry centers. These are the centers already doing the procedure, and we plan to expand and take in more centers from all over the country. They're from north, west, east, south, all over. The patients for interim analysis, which I'm going to present, is 100 patients. 100% of them have, completed 1 month. And SAE out of these has been only 1%, not related to device. This is the age, 58 average age, with more than 3/4 of them are males, with multiple risk factors: diabetics 20%, prior myocardial infarction 8%, renal insufficiency 3%, and ejection fraction has been around 45%. Now, as you can see, about 61% of the patients enrolled have ST elevation MI used in a primary PCI, followed by unstable angina in 18%, non-ST MI 10%, stable angina 9%, and just, silent ischemia seen on a stress echo or a treadmill 2%. I'd like to emphasize that it has been used in a hostile environment of ST elevation MI in the more than 50% of patients. Angina assessment, very little angina at the end of 1 month, and that also stable in a multivessel disease patient where complete revascularization was not done, and 1 patient with unstable angina. Lesion characteristics, the lesion length 28 millimeters, reference vessel diameter is around 3, and mean stent length which has been used is rather long, about 27.5, stent diameter around 3.12, maximal deployment pressure 14 atmospheres, and then most of them had a high pressure dilatation within the stent. Left anterior descending artery more than 50%, followed by right coronary artery in 36%, then circumflex, and 1 case of left main. Clinical endpoints, as you can see, all of them at 1 month follow-up are showing excellent result. No problems, no MACE, no device-related, no patient-related adverse factors, and none of them required another procedure in the first month. And no usual antiplatelet regime has been done. Since most of them are, more than 50% are acute coronary syndromes, it is a combination of aspirin and ticagrelor in most of them. Device success, lesion success, procedure success, 100%. Once again telling that, it's a very user-friendly device and gives you basically good acute results. So in summary, 90% of the patients in this study have been with acute coronary syndrome, and 16% had double vessel disease, 11% had triple vessel disease. So total of 131 lesions treated, mean lesion length being about 28 millimeters, meaning that long stents have been used in the majority, with a reasonably good vessel diameter of around 3 millimeters. All of them received dual antiplatelet therapy at discharge, and at the end of 1 month, there has been no problems. Since we have enrolled about half of them, now we need to focus more on the patients and faster in the 200 patient sub-study of QCA and OCT. So we are pushing those centers to do these procedures in good numbers so that by the end of this year, we should be able to get you the complete results. So the present demand data shows clearly that it's a very good deliverable stent with a very good short-term efficacy and safety profile, and we hope and look forward to its long-term results at 1 year, and then, of course, being a registry, we can follow it every year also clinically. Thank you very much.
Now for the last part of our luncheon symposium today, Unblock with Confidence. It's all about managing complexities and complications that arise in the cath lab. And for that, we have Dr. Hitendra Bhagwatkar, who has agreed to be part of our symposium and take us through how he has actually addressed a case of managing a complexity that arose, and this actually is a live case. So without further delay, I'd like to welcome Sir onto the stage.
Good afternoon, everyone. Thank you for giving me this opportunity. Thank you, Call sir. So I'm already doing the study, and in between the study, we have a complex and serious patient. He came and we have used the stent. I would like to discuss this case with you. So he was a 65-year-old male who was admitted with inferior wall MI. Non-hypertension, non-diabetes, EC showed inferior wall MI. Echo was having fair LV function, and he was a known case of hypothyroidism since 2 years. EC showing acute inferior wall MI. This was an angiography. So angiography showed triple vessel disease with LAD proximal 90% lesion, LCX mid 80% lesion, and RCA was ectatic with proximal critical 90% calcific lesion was there. So as it was a triple vessel disease, we have advised a CABG, but the patient and the relatives denied, and then we planned to do the angioplasty of the culprit vessel, the RCA. So we proceeded ahead with the angioplasty. So we engaged with a JR 3.56 range and attempted to cross with the wire. But while manipulating, there was dissection of the osteoproximal RCA, and there was slow flow. The patient had increased chest pain, there was increased attenuations in the leads, and there was drop in his blood pressure. So proximal RCA dissection, the patient went into bradycardia with junction rhythm and continuously complaining of chest pain, and he was in shock. We have started inotropes. We again reattempted to cross the wire, but now this time we were able to cross the wire to the dissected flap. But while doing so repeatedly, the patient, the whole symmetry and the catheter got disengaged, and the patient went into heart block. We have to put an emergency temporary pacemaker, and it was already compromised, and we have started high inotrope support. This was the last shoot which was showing there was a complete 100% occlusion. Actually, the catheter got engaged into the dissection flap, and we were not able to see. And it was a nightmare which happened in the cath lab. So we were planning to shift for urgent CABG, but there was not much time and the patient vitals were deteriorating. So we planned to again reattempt to engage with the catheter. So this time we were lucky that the guiding catheter was engaged, and we were able to pass through the dissection flap, the wire. And you can see after engaging, there's a well-flowing catheter. So with the help of the guide liner, we have crossed the Eternia 2.4 in 24 drug-eluting stent, and because of the good trackability, we didn't have any difficulty to cross the lesion and also to cross the calcified segment of that. And we expanded, gone up to the 12 atmospheric pressure, and this was a final result. There was TIMI3 flow in the RCA, and the patient was saved. 6 hours post-procedure, hit vitals got stabilized. We have tapered off inotrope support, everything. And next day, we have removed the temporary pacemaker. After 3 days, we have discharged the patient. And now it's been 6 months, he's doing very well. There are no complications in the patients is there. So the key insight is there, what we learned from the case, that there should be a proper assessment of the tortuous lesion. Being a RC dominant vessel, we should have put a temporary pacemaker. Guideliner should have been used in the first hand to support the balloon and the stent. And the choice of Vercos wire is important. Overall, from the case, we had very good experience with the Eternia stent use in such a complex lesion and in such a nightmare. And it really helped to get out of the nightmare and save the life of the patient. Thank you. Sir, any questions? The thing which I felt that I should have used IVUS for assessment of the dissection flap, but there was some financial constraint also. It was the patient was very much compromised, so we were like in a hurry to put the stent. But I think the end result was good, and the stent also expanded very well. Instead of the calcified lesions also, there was no need of doing a post-dilatation also. It expanded very well. Yeah, thank you.
Thank you very much, Dr. Bhagwatkar. So that essentially brings us to the close of this lunch symposium today, which we had themed as Unblock with Confidence. Thank you very much to each and everyone present in this hall during this lunch break that we have. And we look forward, we invite all of you to visit us in our stall, which is stall A2 in the hall number 3. Thank you very much again, once again.